हेलो जगत, आवाज आ रही मेरी?
हाँ।
Good afternoon, everyone. Am I audible?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Yeah. Yes, Krishas, you're audible.
Hi.
Finish my talk, then you can start the cases. Okay.
माइक ऑन है आप अपना माइक बंद कर दीजिए
आवाज नहीं आ रही है लेकिन they are speaking. Good
Good
afternoon.
afternoon, madam.
गुड आफ्टरनून टू एवरीवन
Good afternoon. Maximum. The correction is the mood correction.
तो डिम्पल का सन है इसमें
म्यूट करना
आप ही कर दो कोऑर्डिनेट सारा. Good afternoon, everyone. Thank you for joining this important webinar, which is on amoebic meningoencephalitis. We have a list of various experts who are going to talk today and apprise you on what is primary amoebic meningoencephalitis, what is the epidemiology, how we can diagnose this, what are the treatment and management guidelines, and what are the preventive and community
Excuse
engagement.
me, not audible. Not audible.
Not audible. Okay.
माइक ऑन
Is it better, Dr. Umar?
Audible.
Am I audible now?
Yeah, you are audible actually.
Okay, okay. Thank you. Thank you, Dr. Rahul. So once again, good afternoon, everyone. Thank you for joining this important webinar. We are awaiting just one more facilitator to join. However, we are starting now. We have list of experts who are going to talk today about what is the epidemiology of primary amoebic meningoencephalitis, what is the case management and diagnosis that we can use to diagnose, and what are the preventive and community engagement strategies that we can implement. Starting, we have our head of department for Center for One Health, Dr. Naveen. Along with him, we have Dr. Simit Tiwari, who is Joint Director and Officer in Charge for Center for One Health. With me, we have Dr. Ajit, who is Joint Director at Center for One Health. Now, I would request Dr. Naveen Gupta to please address the participants, and then we can move forward with the presentations.
Okay. Thank you, Dr. Deepti. Good afternoon, everyone. Today, I welcome all of you for this One Health e-learning round. And the topic is amoebic meningoencephalitis, epidemiology, diagnosis, case management, surveillance, strengthening, and public health preparedness. So, as I see lots of experts, they are there from Kerala, from Baby Memorial Hospital, Dr. Umar, Dr. Krishan Das, and then Dr. Rahul from JIPMER, and many other people, Principal Scientist Ajish Kumar, and Dr. Somendra from Department of Infectious Diseases, Dr. Sita Ramanan from STM, Kolkata, and many other participants from Sri Chitra Trinol Institute also. So they'll be talking in the various aspects. But at the outset, I welcome all of you along with my team of Center for One Health. And I really appreciate this effort because if you see primary amoebic meningoencephalitis, it's not a routine diagnosis. It's a diagnosis where there has been a good work done by the clinical side, good work done by the diagnostic side, so as to have the clinical high level of index of suspicion. And in that context, I must say, once we say the diagnosis is PAM, the irony is even when we make so much of effort to make a diagnosis, still we do not have a very effective therapy. Once I say a effective therapy, it means we do not have a very standardized clinical protocol for the management. Now, once I say that, what I'm referring to here is that despite the in vitro effectiveness of the various treatment modalities and the medicines, when it comes to the in vivo administration of the drugs, they really don't seem to work that well. If we see over the period of time, once the PCR for these free living amoeba, which we call as FLA, which was not that widely prevalent, I remember the times, long time back, I diagnosed one case of this PAM from Rohtak. During that time, I was doing my senior residency, and one of my, PG students came to me that there's something moving structure I am seeing in the CSF, and that was a wet mount. So very recently, during those years, I had taken training on free living amoeba from PGI Chandigarh, from Dr. Nancy Malla and ML Dubey. So it was very obvious to me that this is some very interesting trophozoite flagellate form which is seen in the CSF. So the differential diagnosis becomes simple. And then the clinical interest was there. So immediately we went to the wards and then interacted with the clinical medicine department. And subsequently, we could even grow the organism, Naegleria fowleri, on the culture. And, there were again many more experiences with regard to the free living amoebas, say in particular for the acanthamoeba, because, as far as the existence of these free living amoeba is concerned, it's fairly common. It's present in the water, it is present in the environment. But the differentiation point to my understanding is Naegleria fowleri is little more hardy. It can survive in the high range of temperatures. And the other two forms, they learn to survive by making the cyst. And with regard to the immune system or immune reaction, as they get into the human body, they are not easy to diagnose, not easy to suspect. So we would like to understand from all the experts from all over the country. You people have been the best. And in this round, we have chosen all of you so as to understand more at the national level what else the government of India can think, envisage, or do, and learn from your experience. So on that account, I hand over to Dr. Simi to make few comments.
Thank you, sir. Thank you so much. At the outset, I welcome all the experts, eminent experts, those who have specialized in this particular area of interest, amoebic meningoencephalitis. And thank you so much, sir. We understand Dr. Naveen Gupta, sir, additional director, and he is now heading Center for One Health and Center for Arboviral and Zoonotic Diseases, and a seasoned and a very experienced microbiologist. Thank you so much, sir, for encouraging us to hold this very important webinar, which we were talking since many months. But as sir has taken a charge as a head for Center for One Health, so we have been really pushed by him to organize this important webinar, because this is a primary pathogen of concern which is having a serious mortality figures, means in terms of not only in terms of volume but case fatality rate to the extent of more than 90%, but still remain unreported or maybe undiagnosed due to various limited expertise at the level of clinicians or at the level of microbiologists. I will not say the limited expertise, but I will say a limited clinical index of suspicion for this particular disease. So because we understand that AES spectrum, that is one of the primary public health concern once we look into the neurological manifestations of the acute febrile illness or acute undifferentiated fever. We know most of the there is a lot many etiological agents which are being primarily concerned and primarily diagnosed for having this meningitis and meningoencephalitis. We understand viral, bacterial, fungal, and protozoan, but to some extent, protozoan are little less familiar to be practiced in the clinical side or in the microbiological side. If we look into the clinical, etiological, or microbiological spectrum, there are a lot many pathogens which are encountered for meningitis and meningoencephalitis. But this particular pathogen that remain a little less familiar with in the clinical microbiological practice. So that's why, sir, we have all the cases that has been reported from the Kerala only. As with the other diseases, with the other outbreaks, Kerala that has been on the forefront in diagnosis almost all the pathogens, including Nipah and many other high threat pathogens. So again, this leadership is again taken by the state of Kerala. So I must congratulate Kerala and Kerala government. They have come up with a dedicated technical guidelines to address this particular pathogen. So that is one thing. But at the same time, we need to understand the clinical depth of this particular subject, not only in terms of the epidemiology, outbreak potential, environmental surveillance, preventive modalities which we should be adopting. We should know how the disease presents, and is there any kind of pathognomic feature which can alert the clinical physicians so that we can detect it early, or we can have some kind of early warning signal. And at the same time, we also need to understand the limitations with respect to the microbiological diagnosis and challenges encountered in the lab. So with this, we have framed very carefully in consultation with the various experts the agenda for the today's e-learning session. And this is the session 6 of the e-learning session series under Center for One Health. Again, I welcome all the experts. And with this, with the permission of Chair, Dr. Naveen, sir, I would like to introduce first. Before we go, I would request all the experts to kindly introduce themselves. So we can begin with Dr. Umair, sir. Sir, can you please introduce a brief introduce from your side, sir? Over to you, sir.
Thank you, madam. Thank you, madam. Thank you, Dr. Naveen sir and my friends. I am Dr. Umar from Calicut. I head the Department of Neurology at Calicut, Kozhikode, in Kerala. And I've been in discussion with madam over the past few months regarding to have this amoebic and meningoencephalitis, and we had talks on Nipah also last year. So thank you very much.
Thank you, sir. Now I would request Dr. Krishan Das sir to kindly introduce a brief introduction from your side.
Good afternoon, everyone. I'm Dr. Krishnadas Sensi. I'm Senior Consultant Neurology at Maitra Hospital, again from Calicut, that's Kozhikode from Kerala. So I'll be presenting a couple of cases, one right from 2019 when one of the earlier cases detected from Kerala, and one patient who is just discharged now. So nice to talk with all of you. Looking forward for a very interesting session.
Thank you, Dr. Krishan Das. Now I would request Dr. Rahul sir to please give a brief introduction of.
Yeah, good afternoon, everybody. And at the outset, I would like to thank the organizers for inviting me. I am Dr. Rahul Thodapkar, Professor and Head of Department of Microbiology at JIPMER.
Thank you,
And
sir.
yeah,
Dr. Dr. Agish Kumar, sir.
Good afternoon, madam. Hello, sir. Thank you for this wonderful opportunity. Myself, Ajesh Kumar. I am a senior principal scientist from Institute of Advanced Virology, and I am heading the Department of Clinical Virology. Thank you.
Thank you, Dr. Agish. May I now request Dr. Somendra, sir?
Good afternoon, ma'am. I am Dr. Somendranath Haldar, Head Department of Infectious Disease and Advanced Microbiology from School of Tropical Medicine, Kolkata.
Welcome, sir. May I now request Dr. Sita Raman, sir, to
Hi.
please introduce.
All good to be here. I'm Dr. Sitaraman. I'm heading the School of Public Health at Pondicherry, Sri Balaji Vidyapith. Good to be here. We will be discussing the public health angle of the disease. Thank you.
Thank you, sir. Now may I request Dr. Biju Soman, sir?
Thank you, ma'am, and good afternoon, sir. I'm Biju Soman. I'm a professor and head of former head of the public health unit of Sri Chitra Tirunal Institute for Medical Science and Technology. We are situated here in Trivandrum, Kerala. I'll be speaking about the IEC and BCC activities. Like when we are looking at this palm cases, all over the world, the fertility is around 97%. But when we are looking at the cases in India, you can see the survival rate is around 24%. So that's why I'm taking you to some of the IEC BCC activities here in Kerala. Thank you.
Thank you, sir. Thank you so much, sir. With me, I would I take this opportunity to thank the Japaigo team, Dr. Deepti Mishra. She is working hard to organize this webinar and conceptualizing the agenda and contacting with the experts. And with me, Dr. Ajit Shevale, Joint Director from the Center for One Health, is also there, and other team members from Center for One Health. Sir, just on a lighter note, I would request that when we talk about PAM. So PAM also stands for pulmonary alveolar microlithiasis. So there are so many, acronyms which, utilized as a PAM. So I was, just reading last night only about the subject in depth before I go on the epidemiology of this primary meningoencephalitis. So sir, with your permission, can we go ahead?
Yes, please go ahead with the first presentation.
Yes. I think we are audible to all the participants. So नहीं वो तो मतलब ये कुछ साइन दे सकते हैं? Visualize. Yes, okay. Is this being visible? Can anyone confirm?
yes.
Thank you, thank you. So, about epidemiology of primary amoebic meningoencephalitis, the causative organism is belong to the protozoan family.
free-living amoeba, which are widely distributed and inhabiting the environment in the soil, freshwater, and other moist environment. There are 4 free-living amoeba, Nigularia fowleri, Balamuthia mandilaris, Sapinia species, and Acanthamoeba, which are responsible primarily for the human amoebic meningoencephalitis. We understand there are 2 pathological forms for this disease: primary amoebic meningoencephalitis, which is an acute form, and the chronic form, which is insidious in onset, and granulomatous amoebic meningoencephalitis. Morphological and biological features of pathogenic free-living amoeba, which has been described in this table. The life stages are almost similar for all the 4 species which we are talking about. But if we look into the Nigularia fowleri, which is a primary pathogen to cause primary amoebic meningoencephalitis, the infective form for this particular pathogen is trophozoite, which ranges from the size between 7 to 35 micrometer. And the unique feature that this pathogen is found in the hot water springs, or it is somewhat thermophilic in its nature. And India being a tropical country where the hot environment ranges from approximately for 6 to 8 months. So this pathogen causes a great concern from the public health perspective. Next pathogen of concern, Acanthamoeba, which causes the keratitis and which is found commonly in the contaminated contact lens solutions. So again, the infective form is both in this for this pathogen trophozoite as well as cyst. This is somewhat bigger in the size, 10 to 45 micrometer, and the unique feature that it contains a double-walled cyst. The next 2 pathogens, which we are not talking about, but primarily we will be talking about the Nigularia fowleri as a primary pathogen of primary amoebic meningoencephalitis. What we understand by primary amoebic meningoencephalitis, it is an acute, fulminant, and rapidly onset fatal disease of central nervous system, and primarily caused by Nigularia fowleri, as I have already spoken about in the previous slide, and it is commonly known as brain-eating amoeba. The incubation period that ranges from 1 to 14 days as per literature, but we have seen the cases in the literature that some rapid onset that has been that within 9 days or even within 5 days, the patient has succumbed to infection. So we have seen a couple of cases, and in the next few presentation, we will see that the rapidity of the fatal nature of this particular pathogen. It affects healthy, immunocompetent as well as immunocompromised children and young adults, those who are physically active. So basically, the group which is being affected, they are considered to be physically active. Those who are mainly active in water recreational activities. So many of the case histories they have given, but surprisingly, we have come across in the literature that some of the cases which has explicitly did not give a history of contact with the water. So that is again a surprising feature when we dip down in the clinical history of affected patients. If we look into the global burden of these cases, more than 39 countries that has been found to be reported. Although we understand that this pathogen is largely underreported because of limited clinical index of suspicion among the physicians, as well as limited technical expertise with the labs. But it is largely affecting the tropical and subtropical region due to environmental factors and due to climatic factors. Fewer than 500 cases are reported globally. So that the uniqueness of this pathogen, that again creates a kind of interest in the coming fraternity of the public health as well as the microbiologist, and the case fatality reported to the extent of 95 to 97%, and mainly children and young adults are affected by this pathogen. India, most of the cases they are reported in the Kerala. And other states in the south side, Tamil Nadu and Karnataka, they have also reported few of the cases. A shift from the rare sporadic cases to a significant localized outbreak, but again we need to carefully understand the nature of this outbreak, whether the cases are actually belonging to this category or they are misdiagnosed or overdiagnosed. In India, if we see the reports from the Kerala, before 2023, 26 cumulative cases were reported. Recent trends, the increase is driven by state-specific clustered outbreaks. Kerala, since Kerala alone, they have reported more than 200 cases as of now. In 2025, 170 cases and 42 deaths are reported. So this is something, a cause of concern as a public health specialist and as an epidemiologist, that when we are saying on one hand that the case fatality rate is more than 90%, but on the other hand, when the Kerala is reporting 42 deaths out of 170, so somewhat 40% case fatality rate or more, approximately less than 40% case fatality rate, so that we need to understand the clinico-epidemiological feature of this particular outbreak, which has been reported by state of Kerala. Due to limited awareness, misdiagnosis, often as a bacterial meningitis, the true burden of India is likely underestimated. And we know that India per se do not have a strategic environmental surveillance in place. So that may be one cause. And also when a patient land in a neuro OPD or in a general OPD, coming with an acute undifferentiated fever or acute AES, acute encephalitis case, the pattern of history eliciting that varies to a great extent, and this particular aspect of exposure to hot water or exposure to water that is not elicited. So that again limit the extent of suspicion among the treating physician. Rising temperature and climate variability also expand the ecological niche pathogen and potentially increasing the future risk. So that is a cause of concern for us, and it fit this case to have a strategically developed environmental surveillance in the country like India. Children and young adults, particularly male, those who are engaging in the recreational activities, they are more frequently affected. This particular slide is showing the life cycle of the Naegleria fowleri, and I was particularly interested to know the natural history of this pathogen. And if we look into the overall incubation period of this disease, it ranges, as I have spoken in the previous slide, it ranges from 1 to 14 days. But infection timeline in the humans, day 0, can we have this? Day 0, the trophozoite enter the nose while suspected person has swimming or diving or using the contaminated water for nasal irrigation. Then this trophozoite, the infective stage of this pathogen, that migrates, attaches to the olfactory mucosa and then migrates along the olfactory nerve and gain entrance through the cribriform plate into the brain. Then day 3 to 7, the pathogen further progresses and causes a rapid inflammation, necrosis of the local tissue, and hemorrhagic brain destruction. And then after day 7, the initial symptoms are known to appear in the form of headache, fever, nausea, and vomiting within 5 days. And although it can range up to from initial stage from the day up to the day 9, and then outcome, the disease further progresses to the and the patient can succumb to the coma and death and fatality to the extent of more than 90% within 3 to 7 days of hospitalization. This particular slide is about the immune response and the pathogenesis of amoebic meningoencephalitis. Amoeba entering via the nasal cavity, then activation of microglia and astrocytes, releasing the cytokine. And we have seen that the cytokine storm that also come into the picture. and giving rise to a fulminant response, immunological response due to this pathogen. And then cytokine recruiting the neutrophils and macrophages, and then disruption of endothelial wall, and then leading to the vasogenic edema and increase in the ICT or intracranial pressure, and further leading to the neuronal injury. So these are the critical pathogenesis which is happening once the pathogen gains entry into the central nervous system. This we have tried to differentiate between the acute feature of this disease and the chronic presentation of this granulomatous amoebic meningoencephalitis. The onset is for the PAM, the onset is 2 to 15 days, and the subacute form of the granulomatous meningoencephalitis that is known to be a chronic in onset. The course is rapid, and it turns out to be fatal approximately in 48 to 72 hours. Whereas the granulomatous acanthamoeba, it is largely slow and progressive in nature. Symptoms: headache, fever, and nausea. But in the chronic form, the onset is of seizures, focal deficit, and behavioral changes. It mostly the PAM mimics the acute bacterial meningitis, whereas the chronic granulomatous form that mimics the space occupying lesion or the brain tumor or the chronic meningitis. CSF findings, they depict increase in the neutrophils, increase ICT, and amoeba. They can be seen in the wet mount of this. When a microbiological diagnosis is taken as a wet form, then we can notice the free living motile organism. Whereas CSF finding in the case of granulomatous granulomatous form, we can see the mononuclear cells, and there are some other findings which are peculiar in the granulomatous form. There is some difference in the patient's characteristics. The patients affected in the primary amoebic meningoencephalitis, they belong to a healthy children and young adults, those who have been exposed to a fresh water. But the chronic granulomatous amoebic meningoencephalitis, they are is mostly affecting the immunocompromised. But sometimes the healthy people, they also get affected due to granulomatous amoebic meningoencephalitis. Pathology, when we look into the pathological or histopathological examination, in the primary amoebic meningoencephalitis, the hemorrhagic necrosis is found, and polymorphonuclear infiltrates, they are very peculiar to be found. And in the granulomatous, the perivascular trophozoites, they are found, and clear-cut granulomas, they can be seen in the histopathological findings. Mode of transmission. Entry point: the amoeba must enter through the nasal passages, and once inside, it attaches to the nasal mucosa, penetrates the olfactory neuroepithelium, and migrates along the olfactory nerves to the brain. Common source: most of the infections are linked to the fresh water bodies like lakes, rivers, ponds, and hot springs. But there are some secondary sources are also identified. In the rare cases, the infection can come from the inadequately chlorinated water, especially the swimming pools, splash pads, and also while exposure to a contaminated tap water supply. This is also important that it is not person to person. There is no transmission happening human to human, and it is not considered to be contagious. So that is one good thing about the pathogen. That so this is again slide showing some of the environmental and behavioral risk factors. Environmental reservoirs, as the pathogen is a free living amoeba and commonly encountered in a tropical country in the hot water springs, especially in the summer months. Poor chlorination, that is one of the important risk factor, especially when we talk about the exposure which is happening due to the swimming pools or the recreational ponds. Behavioral exposure, having a nasal irrigation, that is a habit of nasal irrigation, mostly practiced these days in the yoga classes. So that is again a cause of concern. And if we look into the new holistic health practices these days, the hot water or the nasal irrigation, that is one of the practice. So that is one of the important preventive measure that we can teach the community to get the prevention. Clinical features, we have already spoken about this. Mostly the constitutional features, and then leading to the convulsions, body shakings, and focal neurological deficits. Diagnosis of PAM, I think subsequent speakers, they will be talking in detail about the diagnosis of PAM. But the lab diagnosis, when we talk about the lab diagnosis of this particular pathogen, it is established by a wet mount, wherein we found the mobile trophozoites of 10 to 25 micrometer in size in fresh CSF of the suspected patient. For confirmation, again, we depend on the PCR and PCR of the CSF sample, and also we understand it can be cultured. The pathogen can be cultured, and the a biopsy of brain tissue can also be stained and examined under a microscopy or analyzed using PCR. Serology is, I don't know whether serology is available for this particular pathogen, but as what we have found in the literature, that it is not going to offer much useful information. Environmental samples, they are important to be examined once we look into the public health aspects and preventive measures to be adopted for this particular pathogen. Risk communication is important. We need to maintain a high index of suspicion, especially we need to take some kind of more teachings and more CME sessions for the treating physicians and clinicians, those who are encountering the patients in their routine OPDs or in the neuro OPD, specialized OPD. Once a history of freshwater exposure is there, the CSF should be promptly examined, and there should be a close communication between the treating physician, microbiologist, and the super specialized facility of the super specialized neurology department. So that is not frequently happening. So we usually see there is a typical gap in communication, which is between the treating physician and the microbiology department of a particular health facility. That's why also the low diagnosis is happening for some atypical cases like this. Community awareness, again, a mainstay of preventive strategy for this particular pathogen. We need to have some kind of strategic behavioral change communication to be in place, so that these cases could be prevented, and also some kind of in the wherever there is recreational activities are happening, we should paste some kind of information for the people, those who are indulging in some kind of recreational activities in the suspected environment. Key messages, it is an acute fulminant central nervous system infection, and primarily caused by Naegleria fowleri. And disease typically occurs when the people swim in bodies of warm water. So we have already spoken about this. But again, when we look into the incubation period, that varies between the different species, ranging from 1 to 9 days for Naegleria fowleri to week for the Acanthamoeba species, which is causing the granulomatous amoebic meningoencephalitis. The clinical presentation of PAM is often similar to the other etiological agents, ranging from not only from the bacterial but the viral meningitis, and also it is presenting with the common features, and therefore the high index of clinical suspicion is of paramount importance. Again, the lab capacity that has to be built for this particular pathogen, and by special training that has to be undertaken, because looking into the microscope, a wet film of a CSF, there may be many artifacts, and it needs a highly specialized, highly technical skilled among the microbiologists. And of course, we need to have some kind of strategic BCC, some kind of strategic behavioral change communication and preventive modalities in a systematic way in our public health facilities. Largely, the pathogen is only detected in the tertiary care institutes, but diving up to the secondary level facilities means a district level health facility, at least, to create a clinical index of suspicion that remain a great challenge for our health system as of now. So with this, I end this, but there are some key questions from my side to the subsequent speaker as well as the fraternity, those who are joining this particular session. What strategies we should be employing to enhance the clinical index of suspicion? So we know that great eminent speakers are among this, but we want to work on this particular pathogen, so we need to have some brainstorming discussion on this. Are there any characteristic or pathognomic clinical feature that can aid in early suspicion and differentiation of primary amoebic meningoencephalitis from the other causes of acute meningoencephalitis? So that we would like to know from the treating physicians or the neurologist, those who are presenting in the subsequent sessions here. What are the key evidence-based preventive measures for reducing the risk of PAM in uncontrolled freshwater environments such as ponds, lakes, and recreational water bodies? What is the role? What we understand that only chlorination that has been given in most of the literature and also in the Kerala guidelines. But whether there are other preventive measures also, other measures wherein we can limit the spread of this pathogen, or where we can limit the growth of this particular free living amoeba. And what is the role and significance of environmental surveillance and how it has to be established? What should be the strategic geographical locations to target for the environmental surveillance for limiting the spread of this disease or for limiting the cases of PAM? And what should be the risk assessment strategy? And how we can further address this particular pathogen from the public health perspective? So thank you, and over to the next speaker, please. Thank you very much.
Thank you, ma'am. So our next speaker is Dr. Umer. He's a senior neurologist with 20 years of experience, and he's working in Baby Memorial Hospital. He's highly qualified with advanced training in intervention neurology and clinical research. His expertise comes in stroke care, neurological interventions, and neurodiagnostic with large case volumes. He has been recognized with multiple national and international fellowships and awards, including contribution during Nipah outbreak. I would request Dr. Umer to please give a brief presentation on clinical presentation and pathogenesis of PAM. And I will also request our speakers and experts to please limit to their timeline so that we can end the webinar on time. Thank you. Over to you, Dr. Umer.
Thank you very much, madam, and all the group at the Center for One Health. And at the outset, we can go to the next slide, please. This is one of my colleagues with whom I was in contact, because we had so many cases of primary amoebic meningoencephalitis. Dr. Rauf. Next slide, please. Yeah. Last year, there is a havoc in the media. There is one boy from Munnar. It's a very good tourist spot. One boy came and he was found to have meningitis and something like a meningoencephalitis, and was reported, and he died after a couple of months. And was, when we diagnosed, he had a primary amoebic meningoencephalitis. That's the first time the people are really knowing about this particular pathogen. Next slide. As Madam was telling, I'm not going further because it's a brain-eating amoeba. Is found everywhere except in sea. There is I think there is one area where you can really go and have the water sports. Sea, there is no reports from sea so far. And it is something like exactly like a bacterial meningitis, but with a rapid course, it is something maybe with the meningoencephalitis. Fever, headache, altered sensorium occurring within a matter of few days, 1 to 2 days, and death within another couple of days. That's how this behaves. And the portal of entry, I think Madam has exquisitely explained how it goes through the olfactory neuroepithelium, especially young kids where the cribriform plate is not well developed. So what happens is once they jump or once they splash or once they're getting a irrigation, so the water, the contaminated water can go through the porous cribriform plate and can gain entry into the subarachnoid space. And the result would be some edema, necrosis, herniation, and sometimes death. And in most of the cases, it's death. Next slide. Okay. So I think this all explained. The only thing is that while swimming or irrigating or during ablution or any other water sports, especially young kids, because most of our cases are young kids with age of 5 to 15 years. Those age, the nasal, the upper part of the nose, the cribriform plate is poorly developed. So they can rupture and can the organism can gain entry and they can cause meningitis. And the organism, as Madam was saying, this goes along the olfactory nerve, olfactory bulb, and tracts to the brain, causing profuse, destruction of the brain with hemorrhagic necrosis and rise ICT, intense inflammation and edema, and within a few couple of days, death. Next slide. This is, I think, already mentioned. Madam already talked, so I'm not going into detail. Next slide, please. So, as you know that, once the FLA, the free living amoeba, enters into the brain, it's been reported since 1960, and around 488 cases were reported. And in Kerala, we had around 211 cases so far. This amoeba, by multiple mechanisms. One is a contact-dependent pathogen mechanism. They adhere, and because of the amoeba storm, they cause something called a phagocytosis. They engulf the brain cells, and it's rapidly destroy the brain, causing something called literally say eaten brain or something like something like that. And secondly, this can cause a cytokine storm because of the various substances like the phospholipase, neuraminidase, as well as various the cytokine like reactive oxygen species, nitrogen species, interleukins, and the interaction with the various neutrophils, eosinophils, and other things. Sometimes what happens is in some of the patients, two cases I've seen that one lady came with a ear pain, severe ear pain. She had taken to a ENT doctor where he prescribed some medication. Next day, she became altered and he had a irrelevant talk and he was intubated and ventilated. This is a rapid onset. I saw two such cases. One case, the investigation showed that he got primary meningoencephalitis, and the biopsy showed a pneumococcal meningitis in addition. The second case was the same thing, ear pain, severe ear pain, next day altered symptoms. It's something like a meningitis, classical meningitis, pneumococcal meningitis. But in addition to the meningitis, there is a primary amoebic meningoencephalitis. Actually, it's like a Trojan horse because many things can be hosted by this infected macrophage. They can have a melioidosis, they can have meningococci, pneumococci, funguses, and many other things. So that's one reason. If the patient is not responding to usual medication, you have to do a repeat CSF. Or at the first outset itself, you have to do a wet mount smear. In addition, because most of the time you don't do that. So all cases of meningitis or meningoencephalitis or acute encephalitis syndrome, we have to do a wet mount in addition to whatever you do, like cultures, fungus, AFB, and things like that, so that you don't miss any case of a primary amoebic meningoencephalitis. Next slide, please. So I think this also dealt with by madams. Free living thermophilic amoeba is found everywhere except seawater. Especially young children are getting affected, especially those who dive, those who the water gets into the nose and something like that, like jumping, diving, splashing, and other water sport activities. Next slide, please. So unlike Nipah, I think we have a margin 40 to 75% mortality. Here, until recently, the mortality was around 98%. And the incubation period can start 1 day to 9 days, and it's a very narrow therapeutic time. It dies within a matter of 5 to 10 days. So we have to act, we have to intervene very early. We have to have a very high index of suspicion that this could be, this altered sensorium patient could be another case of primary meningoencephalitis. So we have to look for the wet mount and the amoeba in addition to the biofare as well as the culture. Next slide, please. This is a specimen where you can see there is an extensive exudates and hemorrhage in bilateral frontal cortex, mainly on the right side. Next slide, please. So this is one seminal article by Radhika Garpure in 2021 that is extensively evaluated. I mean, the epidemiology clinical character of primary amoebic meningoencephalitis. Next slide, please. Next slide. Yeah. In those in that article, it was found that it's predominantly male and that to boys, and median age is 14 years. It can start from 1 month to 85. As my madam was telling that those 1 month could be because of the irrigation, because the saline drops or nasal drops or something, the water, the tap water. I mean, they must be using some tap water instead of the boiled water. And the incubation period could be from 1 to 30, minimum 1 day, maximum it can go up to a month. And the case fatality until recently was 92% cases in those study. Next slide, please. And this is how they get the infection by swimming, diving, bathing, as well as various water sports. These are the highest number. Next slide, please, in that article. Next slide. These are the clinical features. The maximum thing is something like a flu-like pattern: fever, headache, nausea, vomiting, altered sensorium, respiratory, seizures, neck stiffness, photophobia, phonophobia, and many other rail nerve abnormalities, sensory abnormality, gait abnormality. But within a matter of few days, this evolved into a full-fledged form like a meningoencephalitis with will be bed-bound, will be intubated and ventilated. Next slide, please. So the early clinical phase is exactly mimic meningitis. Last time when I saw the patient, there's a extensively exudate around the brainstem. So I thought that this could be tuberculous meningitis. The way it looks, it's an exudate around the brainstem, around the cerebellum, around the lobes and all. I thought that this could be extensive tuberculous meningitis, and the protein count was very high, and the low sugar and high protein and cells. But it's the PCR came to be positive, and the wet mount also positive. Similarly, once the patient gets it's not getting better with the usual bacterial meningitis medication like vancomycin and ceftriaxone, always you have to think in terms of primary amoebic meningoencephality. You have to ask for a wet mount and of the PCR, especially in the context of recent bathing in ponds or lakes or swimming pools. Next slide, please. This is the clue. They can have an anosmia just like a COVID. They can have a loss of taste and smell, nasal irritation, and in the context of recent freshwater immersion, always think in terms of a PAM. Next slide, please. So they can have a progressive phase, they have a severe sinus failure, and a terminal phase. They can with altered sensorium to begin with, seizure, hallucinations, some increased rise intracranial pressure, and developing coma within a matter of days. Next slide, please. Next slide. Yeah. So the usual differential diagnosis would be between meningoencephalitis, bacterial meningitis with and viral encephalitis. Viral encephalitis, you know the history, the systemic symptoms, minimal neck stiffness, more seizures, altered sensorium, and meningitis is a severe neck stiffness, fever, headache, and high protein, very low glucose, and high polymorphs. And culture will be positive, grams will be positive. In PAM, in amoebic meningitis, you get the RBC can be found, protein will be high, sugar will be low, but there can be a mixed pleocytosis. Both the lymphocytes as well as the polymorph can be seen. And it usually won't occur with a meningeal bacterial meningitis, but can occur with a viral encephalitis. Next slide, please. So the thing I want to tell you that once you should have a high index of clinical suspicion when you encounter a young boy who recently had a bathe in ponds or swimming pool, come with fever, headache, and altered sensorium. Always ask for a when you do a CSF, ask for a wet mount, at the same time ask for a PCR as well. And we have to look for the RBC, WBC, as well as the protein and thing, along with the neuroimaging. Next slide. So the other thing that Madam already told is granulomatous amoebic encephalitis that I think we haven't seen any cases so far that exactly look like brain abscess, neuro CNS tuberculosis, neurocystic sarcosis, and something like that. Because it is a subacute to chronic concept, and the prognosis is better, I think, because it is a we can remove that. We can the treatment because of the recent introduction of the miltefosine amphotericin. I think we can have a better outcome with this infection as well. Next slide, please. So I think I'm going to end my talk. This is globally around 500 cases. In Kerala in 2020, there are a couple of cases with a 75% mortality. 36 cases with a death of 9. There's a 25% mortality. Last year, 80 cases, 21 deaths, 26.5% mortality. This means that we should have a high index of, we should be aware of this entity and early detection and targeted therapy has to be instituted. Next slide, please. I think before you dive into a water body, think of primary amoebic meningoencephalitis. Thank you. Thank you very much.
To please write your question in the question and answer. Okay, sorry. I would request participants, if you have any questions, please write your question in the question and answer section. And I would request our experts to answer those questions whenever they come. Thank you so much, Dr. Umair. So to summarize what we have learned so far is PAM is an acute, rapidly progressive and highly fatal disease. The common clinical features include fever, headache, neurological deterioration, and signs of raised intracranial pressure. We have CSF findings which often mimic bacterial meningitis, which suggest high protein, low glucose, neutrophilic pleocytosis. However, if you do a gram staining, the stain will be negative because it's not a bacterial disease. Diagnosis require identification of amoeba in CSF or brain tissue using microscopy, PCR, or NGS. And GAE, which our experts have already told, it's in subacute or chronic disease which affects immunocompromised and is often misdiagnosed. So this is the key messages that we had learned from Dr. Umair's presentation. Moving forward, we have Dr. Krishnan Das, who is a senior consultant neurology from Metra Hospital, Kozhikode. He is a former treasurer, Kerala Association of Neurologists. He has numerous national and international publication and presentation. He is also a podcaster, which is on clinical neurology with KD, one of the top international neurology podcasts in 2022. So I would request Sir to take us through a brief presentation on case management of amoebic meningoencephalitis. Dr. Krishnan Das, over to you.
Thank you, ma'am, for the kind words. First of all, let me thank the One Health team for providing me this opportunity. So I'll be presenting two cases. One was like from 2019. Like during those times in Kerala, we used to get 1 or 2 cases per year. That was the thing. And of late it has increased. So I'll be presenting 2 cases, one from 2019 when I first saw this particular case, and one patient was just discharged 2-3 days back. But can we go to the next slide? So this particular case was in, as I told, in 2019. Actually, she was the daughter of our own ENT audiologist. So 12-year-ould healthy girl with fever, headache, and mild disorientation of 3 days duration. So she presented with on examination, she had neck stiffness, papilledema was present. There was no focal neurological deficit. So this is a typical acute bacterial meningitis story. So there was nothing to be confusing about that. So I thought it was meningitis. We admitted the patient. An MRI was done, which showed mild meningeal enhancement consistent with my diagnosis of acute bacterial meningitis. The CSF opening pressure was high. Interestingly, the lab technician, usually people will not look for wet smear. We are supposed, every case of CSF, we are supposed to do a wet smear. And I was working in MS Medical College at that time. The technician does the routine things perfectly well, and she was intelligent enough to detect in that wet smear that something is moving around. She was not able to tell what it was. She told that, sir, there is something moving around in the CSF. So that got us interested. I went and checked that. We got the help of the microbiologist. And next slide, please. So can you play that video? So you can see that small thing at that 9 o'clock position. I hope it is clear. You can see it is changing its shape, just like an amoeba. Yeah, can you see that? I hope you can see that. It's changing the shape, the arrow mark over there. Yeah, that in that 9 o'clock position. I hope. Yeah, perfect. Right. I hope everybody could appreciate that. So this is what we saw there, and the microbiologist came. We discussed. We had no idea at that point, but then when something moves like that, like an amoeba, it has to be amoeba. So we thought it is possibly a acute primary amoebic meningoencephalitis due to Naegleria fowleri. So, but unfortunately, there is no history of any freshwater swimming. But in the CSF, it is supposed to be sterile. Nothing should move like that. So we immediately initiated her on amphotericin B, rifampicin, fluconazole, azithromycin, along with the meningitic dose of antibiotics, and intense anti-edema measures were given. Miltefosine was not available, unfortunately, at that time. But the child deteriorated rapidly. By evening, she died, actually. So she, within 12 hours of admission, the child died. Very unfortunate story, but at least we could know the diagnosis. Otherwise, would have been in a mess. Why bacterial meningitis should die like that even after giving medications? So this is the story of a classical primary amoebic meningoencephalitis. You will not get anything else in the story. It is a typical acute bacterial meningitis of 2 to 3 days, fever, headache, nausea, vomiting, altered sensorium, and when you see, you get a neck stiffness. The only way to, if you get a, so in all cases of bacterial meningitis, you have to get a history of any freshwater exposure like swimming or water sports, which we have already discussed in the last 2 sessions. So, but that may not be there. So the only way to pick up these cases is actually looking for wet smear. It is cheap. You're just basically looking the CSF under the microscope, and you're just looking for anything mobile. And this particular technician was responsible. I had nothing to do with that. She was the person who picked up that case, and then we discussed with the microbiologist. We thought it could be this, and the prognosis, the way the disease progressed, proved that it was a case of primary amoebic meningoencephalitis. Can we go to the next slide? Next slide, please. So the typical treatment for Naegleria fowleri is amphotericin B. It can be given as a 14-day course. Miltefosine, which is now available in Kerala, it's a game changer. It has really improved the mortality. We have seen that in most of the studies from rest of the world, the mortality is around 96 to 98%, while in Kerala, for proven cases of primary amoebic meningoencephalite due to Naegleria fowleri, is less than 50%, and most of the people believe it's mainly because of miltefosine. And then the azithromycin, the sulfampicin, seconazole, all are effective, and they are given for around 28 days. Intrathecal amphotericin B is very effective, and it can be given as a 10-day course. And most of the time, these antibiotics are given along with dexamethasone at a dose of 0.6 milligram per kilogram per day in 4 doses for 4 days. So this is how we treat the cases now, and the prognosis is not as bad as the index case we had. We right now in Kerala, we have almost like nearly 50%. So I cannot the Amoeba, the prognosis is much better. We are getting mortalities of around 25%, but the proven Naegleria fowleri also, it's like 40 to 50, unlike 40 to 50%, unlike the literature which shows around 90%. So I think miltefosine has been a game changer as far as the treatment of Naegleria fowleri is concerned, as far as the early diagnosis and starting the treatment early. And one of the things which has been noticed is if you start the treatment within the first 3 days, the patients have got a better prognosis. So early diagnosis is the key. It's not not based on, of course, if there is a history of a swimming in pond, that helps, but it need not be there. The way to pick up any cases with the meningitis, you have to go for a wet smear examination under microscope. It is cheap. Everybody can do it, and most of the people can appreciate the moment of amoeba if it is there. And again, you have to keep a fresh sample. There's no point in looking at after 12 hours or 24 hours. By that time, the mobility will disappear. Can we go to the next slide? So this is a case two presented like one month back. 12-year-old boy, fever, headache, vomiting of 2 days duration. No typical headache, vomiting, this like that. But he had a history of swimming in pool 2 weeks prior. So because we are all sensitized now, there was neck stiffness present. Fundus was normal. No other focal neurological deficit. So clinically looked like a meningitis. Because of the swimming history, we went for the CSF wet smear. Next slide. Next slide. Yeah. As expected, the CSF showed the motile trophozoites. Again, in the previous case and this case, you can see the CSF. It pretty much looked like a classical bacterial or viral meningitis. You get a polymorphonuclear leukocytosis with increased protein and low glucose. In this particular case, the protein and glucose was basically normal, more like a viral picture, but it's more of polymorphous nuclear cells, suggesting a bacterial meningitis. Again, the case is picked up because of the story. And anyway, we are these days doing wet smear for all the cases where we are doing CSF, and motile trophozoites were again detected. And the CSF PCR, which is available, which was not available back in 2019, we did that and it came as Acanthomeba positive. And meningoencephalitis panel, as is had shown Haemophilus influenza. Now, this is something which Dr. Umar has just mentioned. So many of these cases will have a couple of other organisms to go with it. Why are these people, are they so unlikely to get a Haemophilus influenza meningitis and Acanthomeba at the same time? Next slide. Yeah, this is because the Acanthomeba basically feeds on this bacteria. So this is something known as the Trojan horse concept, because these the amoeba basically feed on this bacteria. Sometimes what happens is the bacteria will not die inside the amoeba. So they will remain there in a protective environment. They will multiply there. So once the amoeba inside it produces amoebic meningitis alongside the amoeba, they will get out and produce meningitis on their own. So you may be confused whether, like with a meningoencephalitis panel, you are getting a influenza or a streptococci, and you think it is a streptococcal meningitis you are treating, but the amoeba will be missed. This is something you have to always take. Or similarly, when you just get an amoeba PCR positivity, you have to always think of other superadded infection, because there may be TB inside its, you cannot call it stomach, inside its body, or there may be there will be a streptococci or a Haemophilus inside the amoeba, which can produce a secondary bacterial meningitis. So this is known as the Trojan horse concept. There's like the Battle of Troy, where the Greeks hit the soldiers inside these wooden horses, and finally the soldiers captured the city of Troy. So it's well known for this Trojan horse concept coming looking like 9-1. Right. Next slide, please. Yeah, we can go to the. So this actually, the Acanthomeba protect the bacteria, and bacteria produce the meningitis later. The Legionella, Listeria, Burkholderia, Vibrio, Mycobacteria, all are well to survive inside the parasite, the amoeba. Next slide, please. To the next slide. So, particular patient was treated with ceftriaxone, vancomycin because of the H influenza post the amoeba measures. So, miltefosine, azithromycin, fluconazole, cotrimoxazole, and rifampicin were given. Patient symptomatically improved. Miltefosine has to be stopped around 5 days later because of severe gas. And continued, and repeat CSF was done at 2 weeks, which showed mild positivity. So we continued the antibiotic for 1 month, CSF, and the patient was discharged a couple of days back. So this is classic. This is not actually the classical story of Acanthomeba. Acanthomeba present as a subacute meningitis, like a tuberculous meningitis. That's what we are seeing more commonly in Kerala. The West as we all know, the granulomatous meningitis or a brain abscess is the classical presentation described in Western literature regarding Acanthamoeba. But what we are seeing in Kerala is more of subacute. It is just like tuberculous meningitis. Next slide, please. So treatment, as I already mentioned, miltefosine again is useful. It's been again, remember, mild cases, it may not be required. And remember, Acanthamoeba, unlike Naegleria, is well known to produce relapse, and treatment may have to continue for up to 6 months. And even if it's PCR negative, you have to always look for relapses. If it is present, the treatment will have to continue. Right? Next slide, please. So this is the reported cases of Acanthamoeba. I'm not going into the details of that for want of time. But what we have to understand is the presentation, even for a lot of literature, the presentation is quite different from the primary amoebic meningoencephalitis, the granulomatous meningoencephalitis we see in Western literature. We are seeing more of this chronic meningitis like tuberculosis sort of cases. So next slide. Our Acanthamoeba patients are different. What we have seen in Kerala. So as sir already told, we had quite number of cases. Now, 1-2 cases before when we had 4 deaths and 2020. So majority of patients are immunocompetent. So what we see in PAM, usually it's immunocompetent. In Acanthamoeba, usually it's supposed to be immunocompromised. What we are seeing in Kerala is most of the majority of patients are immunocompetent. It's usually that Acanthamoeba is difficult, trophozoites are difficult to detect in CSF. Like in the previous case, we are able to detect these trophozoites. Our microbiologists have become quite this. Maybe that's the reason. Mostly, unlike granulomas and abscess, which are possibly because of the Trojan effect, a presentation like stroke, cadum, polyradionopathy is very common. So you do a CSF for a GBS patient, you do it for a ADAM patients. You are getting this happening. Maybe it is because of the again post-infective sort of thing, or maybe we are detecting. That's again a controversial area which requires further discussion. Why that is happening? Maybe it's just that we are picking the because our we are now looking for these particular things, and these might have otherwise did not produce disease because people are immunocompetent. We are just picking them early before they go into that classical granulomatous. So the disease severity is very, as I already told, the mortality less than 25% for Acanthamoeba during the last 2 years in Kerala. Next slide. Yeah, and disease severity is varying. Some of the Acanthamoeba are dying early. Some of them are having good prognosis, like the case which I described. Maybe because there are different phenotypes. Maybe it's because the immunity is different, because the initial exposure is different. We need more epidemiological data and look into the to behaving like the case which I've discussed initially. Most of the disease 2 to 3 days, rapidly progressive, higher mortality of around 50%. But few Naegleria fowleri are showing mild disease, and it's actually there are no reports of Naegleria other than fowleri producing disease. So even one of the cases which has been reported from Calicut is actually non-fowleri Naegleria producing disease, and it's actually one of the first reported case. It's in the case, it's in the course of publication right now. So even Naegleria non-fowleri is producing disease. That may be the reason why some of the Naegleria are mild. To keep this in mind, so why this is important, we have to remember that not all people are very bad. So if this got no side effect, so you have to be careful. If the disease is mild, when the side effects are more, you have to be a bit careful. As we stop miltefosine in our case after 3 to 4 days, you have to be careful. The treatment should not be more harmful than the disease itself. So that is something we have to be very careful. Yeah, Acanthamoeba can be severe while giving medications to these. Next. Next. Please. So these side effects of miltefosine, GI side effects are well known: renal, hepatic side effects, thrombocytopenia, Stevens-Johnson, UV fertility issues in males. So a lot of side effects, but again, in academic as well. The patient is having mild disease, responding well to treatment. You have to be. Next slide. Yeah, as you all know, nephrotoxicity, anaphylaxis, meningoencephalopathy, a lot of side effects. It's useful for Naegleria. It's not very useful for acanthamoeba. You should not give that amphotericin for acanthamoeba. Again, you have to be careful, closely monitor these patients while on amphotericin. Next slide. So why this is epidemic Kerala right now? So one reason we are all so sensitized. We are looking this under microscope, all the CSF we are getting, or we are detecting it. So this is a very interesting paper from PGA, which they did around 160 patients without undiagnosed meningoencephalitis here for free living amoeba. I hope, am I audible? So that may be one of the reasons why we are getting this many type of cases. And another reason may be because of the block in Pakistan, where around 100 cases were reported in the last 10 years. So next slide, please. Yeah, next slide. Next slide. So that is a take-home message. So free living amoeba is a problem we have to deal with everywhere that is there. So whenever you test, you are going to get the amoeba, except for C, as Dr. Omar sir has been telling. So actually, it's quite understanding why more people are not getting it. So for around 10 lakh, actually we are getting only one infection. Thank God for that. Maybe it is changing. We don't know. Academy in
अपडेट करना है उसको
cases, always watch out for co-infection due to the Trojan effect. Treatment should not be more harming than the disease. You have to individualize treatment. Next slide.
Thank you, Dr. Krishnadas. There was some internet glitches, I guess.
Okay.
Dr. Naveen wants to say something.
So I think both the presentations, 1 and 2, by Dr. Umar and Krishan Das, they have been excellent because they talk about the real-time experience. Now I will just catch up with one small comment for Mr. Krishna Das' presentation. In the first case, we diagnosed it on the basis of the microscopy to be Naegleria, and the patient very rapidly died. Right.
Yeah.
In the second case, if we see, we got the acanthamoeba this time.
Yeah.
And there was Haemophilus also. And the regimen which you use very smartly and intelligently, I must congratulate you, because as we treat the meningitis of Naegleria versus, say, acanthamoeba, there is definitely difference in the outcomes. So as a clinician, you will be observing it more often. And that's a small comment I want to do. So in that case, if anybody else wants to make any comment, otherwise we move to the next one. So that was a good one.
The second case had the history of exposure to, they had actually gone from the school to nearby theme park. So fortunately, no other children were affected.
Yeah. See, there are so many interplays which happen, right? There can be the host factors, there are the environment factors, and ultimately it is the determination. And at the bottom line, it's the virulence. And not only that virulence, how fast it is going to progress. So that is what is the determinant in the given case. And supposedly, the clinical side doesn't get the time, the microbiological doesn't get the time to even think of it. So even before they think the organism is doing a job. So that way, Naegleria fowleri is much faster as a fatal organism as compared to the other two. So you have very clearly made that point. Thank you so much. I think we should proceed to the next one.
I have just point to make. So thank you, sir. Sir, what we understood from a underline from a bottom line which you have quoted in one of your slide, that we should be very careful while choosing antimicrobial regime. But there is just one, out of my curiosity, I am asking whether we should understood that the treatment for such a high-end antimicrobials such as miltefosine and amphotericin B should only follow after a definitive diagnosis by microscopy, because these are very high-end antimicrobials and they can cause a great harm. So what is
Definitely. So, yes, ma'am, as you correctly told, you give this thing only once the diagnosis is made. Right now in Kerala, the PCR is available very fast. So whenever, and see the microscope, just take CSF study is done. In 10 minutes, you can see, even our residents are well versed in seeing it now. So the thing is that with just looking at the wet smear, you can do in 10 minutes after doing the CSF, and even the residents are good enough to pick it up now. And our microbiologists have reached such a level that from looking at the wet smear, they are able to differentiate between Acanthamoeba and Naegleria by the presence of these acanthocytes on the surface of this organism. So basically doing a wet smear very fast, just after the CSF, is the most important step. And if your suspicion is high, even if it is negative, you go for the PCR.
And I think we should do that within half an hour. If you delay the the microscopy by after half an hour, then you might not miss it. So even if the person is told that you should have a photo or a videograph in the camera, in the mobile camera, so that next day it won't be there. So immediately at the time, because if it is LP done at night, shouldn't wait for next day for the microbiologist to report.
Can I just give a small tip on that? A microbiological tip, if there are some microbiologists on the side. See, why do they disappear? You said ki within half an hour you may not find it after that. Because
the mobility may be lesser. That's the reason. So
see,
it can be confused with polymorphs and all.
So my point is ki if supposedly in half an hour, supposedly you are preparing a wet mount. Say after half an hour, gently, whatever the vial you have, you just shake it gently before you take a drop for the wet mount. Because amoebae, they have got a tendency to stick to the surface. So if you just shake it gently and then take, it will make a difference. Just a small tip.
Okay.
So, Dr. Deepthi.
Thank you so much, Dr. Umair and Dr. Krishnadas. That was a very informative presentation and session. There are many questions in the question and answer session section. I would request you to please answer those. Moving forward, we have Dr. Rahul. He's a professor and head of department in JIPMER. So he's a professor from JIPMER Institute, Puducherry. He has a clinical and diagnostic microbiology expertise and virology with serological and molecular diagnostics. And he has also expertise in outbreak investigation and surveillance, biosafety and biosecurity, and scrub typhus diagnostics. Dr. Rahul, over to you for diagnostic and laboratory readiness. Will you be sharing the presentation?
Yeah, I'll share it. I'll share it.
I'm stop sharing. You can then share your.
Yes. Are the slides visible?
Yes.
And is it moving?
Yes.
Are the slides moving?
Yes.
Yeah. Yeah. So at the outset, I would thank the organizers for allowing me time to talk about the diagnosis. And I should also confess that most of the things which I would be talking in my talk have already been discussed with an epidemiologic angle and a clinical angle, which is much more pertinent. So anyhow, going forward, as we have already heard, this meningoencephalitis due to free-living amoebae is primarily reported with Naegleria fowleri and Acanthamoeba species. So here in question is most of the cases which are coming from Kerala, where predominant are the Naegleria fowleri, and these are seen in the warm fresh water and has been amply emphasized in the previous talks that these have a very definite association with swimming or any exposure to water. Stagnant water, usually not associated with the free flowing or seawater, and this causes primary amoebic meningoencephalitis. Acanthamoeba, on the other hand, is associated with other types of exposures, which could be other soil or water or others. And as the literature reports, it is the CSF yield is less, but in the previous talk, Dr. Krishnadas, from a very first-hand experience, informed us that they are seeing it in the wet mounts as well. In fact, from my own experience, we had one report when I was a senior resident where we had seen it in a wet mount, and I'll be talking about it when we go to the specific diagnostics. And the third is Palamuthia. So this slide I will very quickly move through. Already this has been discussed. Naegleria fowleri has a trophozoite, flagellate, and a cyst form. And this is thermophilic, causes primary amoebic meningoencephalitis, and has a flagellate stage, which helps us in identifying specifically in microscopy itself. Acanthamoeba has a trophozoite and cyst form. Acanthopodia are there. In the CSF, usually we see the trophozoite form. Cyst forms are seen in other clinical presentations. No flagellate forms are there. Balamuthia again has trophozoite and cyst form, and where this has a broad pseudopodia and a smooth cyst wall. You can see then these morphologies which are there in the image can be there. I have never seen Naegleria, but I have sufficient experience with Acanthamoeba, which we have seen in our routine clinical work. So you can very well appreciate it in the microscopy. Now, practically, when we look at in the algorithm, whenever there is a suspected primary amoebic meningoencephalitis, CSF examination should be done. And as again emphasized in the previous talk, we have to do an immediate fresh CSF mount and a simultaneous PCR. So CSF mount is something which is very, very important. For Acanthamoeba, again, we do not say that you should not do a mount, but the chances are much lesser as reported in most of the literature. We can detect it using molecular tests. You can do it by immunohistochemistry in the biopsy specimen or from the PCR of the biopsy specimen. Radiology shows the features of meningitis as emphasized in the previous talk, where two cases was discussed, where we see diffuse cerebral edema, we do see T2 hyperintensities. However, the imaging is not very specific and doesn't indicate anything towards the amoebic etiology. It talks about how in general meningitis cases would be there. Now I'll be talking about each of these modules individually. First, we talk about the wet mount. So wet mount, usually we should see a fresh unrefrigerated CSF sample where we can visualize the Naegleria fowleri. Trophozoites would show rapid movement, and what is important is that these would be associated with neutrophilia or the polymorphonuclear cells, and this could be hemorrhagic as well, and this would show a marked reduced CSF glucose. CSF protein would be higher. Now here I would just tell, I did not put it in the presentation. When sir was telling, I just remembered a case from my senior residency where in a night duty, I got a call. We used to do from all the immunocompromised cases, we used to do a India ink. And my JR called me and said that in the India ink, sir, we are seeing something moving. And then we went on to do a wet mount, and where we identified it as a acanthamoeba in a CSF from a case which was, I think, HIV seropositive. So we can see it in the wet mount. However, broadly, the literature which comes from West hasn't found it that way. Next, talking about the culture, we can do culture on non-nutrient agar seeded with E. coli, and here either of Naegleria or acanthamoeba can be cultured. And since it's a thermophilic organism, Naegleria is better incubated at 42 degrees. And this would show the tracks on the plates. As it moves, there would be tracks on the plate. And if we make a smear, you can make a smear from where you can see the trophozoites, which are around 40 micron in size. Culture is again more of an academic exercise and is not useful for diagnosis because it does take around 5 to 6 days for the culture to come up and may not be diagnostically very relevant, looking at the pace at which the disease develops. What is important and has come very handy in last couple of days is the molecular testing. Whenever there is lesser suspicion, or right now, if we look at the countrywide scenario, most of the cases are coming from Kerala. But what to do when there is a delayed suspicion or a delayed differential which has been propped up? So in that case, where wet mounts are not cannot be done because the CSF is not available or has been frozen or is kept for 24 to 48 hours, where recovery of viable free living amoeba is not possible, then the PCR comes very handy. And we have standardized protocols on the pan free living amoeba and species specific free living amoeba PCRs, which can be done. And these have a very good sensitivity of up to 1 amoeba per sample. And this can also be done in a retrospective manner. If you have brain biopsies available, we can use those also for a retrospective detection. Additional diagnostics which can be added are standardized assays on LAMP. These are not commercially available. However, there are labs which have standardized. LAMP has its own advantages in resource limited settings. As Madam was telling in her talk, that in the secondary level, if we have to do something, we have to offer where PCRs may not be available. Providing a LAMP-based kit, if it is produced on mass scale, may be a good option. PCRs have been standardized. There are multiple papers. In India, most of the work before this outbreak had been happening in PGI. And from there, in fact, the study which was quoted in the previous talk, I would also be quoting to tell the same data. They have standardized the PCRs, and these PCRs can be used for routine diagnostics. Depending upon the resource availability, we can do everything together, or we can have a tiered workflow where you can do a pan free living amoeba PCR to a species specific PCR. You can do it first as a wet mount. That depends on how the laboratory setup is, how much trained manpower is there, how much manpower is there, because it all depends from the sector of where the hospital is working. Patients won't know where to go. So patients would be there everywhere, but the hospitals and the labs on their own have to devise. And the next thing is archival tissue testing. Now, this question has been repeatedly flagged, that what is so special that Kerala is only detecting, and why other states or other parts of the country are not reporting. If we look at the environmental conditions, the next state which is similar is not reporting as many cases. Tamil Nadu is not reporting as many cases as Kerala is reporting. So we need to go back and see whether in posterity we can see if there are any archived tissues, if there are brain banks where we can go back and see, which would tell us that whether free-living amoebae actually are there in these places, or is it a phenomena which is happening specifically in Kerala. The other important thing which comes, although not very pertinent when it comes to outbreaks where there are cases and where we are having diagnosis just based on wet mounts, but in other parts of the countries where we are not able to detect, metagenomic sequencing is something which is very, very handy when the routine tests fail, which would help us in a label-free detection of pathogen or unexpected diagnosis, or if we want to genotype, if we want to see whether these and amoebae which we are seeing, are they similar to what have been reported earlier? These may be very important when we are looking at the environmental amoebae vis-a-vis the pathogenic amoebae which have been detected, because this all comparison is important. We know that these amoebae are coming from environment, but then see, environment is something which has all sorts of flora, and the free living amoebae are very much a normal part of the flora. They are not abnormal there, but which of them are causing the disease? So for that we need to have some level of sequencing data which should be generated, and I hope the state of Kerala, which has been at the forefront of this, is also doing something with the sequencing as well. In fact, in the subsequent 1 or 2 slides, I will tell you also where a few cases have been detected just based on bioinformatics. Sorry, the metagenomic sequencing. So this is the paper which was presented in the earlier thing also. This is a paper from PGI, Molecular Diagnosis of Encephalitis, caused by free-living amoebae, where they looked at around 156 cases, and they found 2 Naegleria fowleri, 6 Acanthamoeba, and 3 Balamuthia, total 11 positives. Their main conclusions were reporting using PCR, which gave us a very rapid result. This could be probably because it's a reference center and might not be directly handling the samples, and they get samples from all around the country, including the state of Kerala, where at least some labs, which I know the people there had been sending the samples to them, and it has a 100% agreement with the other confirmatory tests. And they have recommended a tiered thing where we can do a pan free living amoeba PCR first and then a species specific PCR. These are some case reports where which are interesting. I'll just tell a little bit about each of them. This is one case where a 14-year-old male patient was diagnosed with primary amoebic meningoencephalitis, and here the diagnosis was based on metagenomic next generation sequencing. This is something which we now need to develop. This most of the laboratories across the country have got the next generation sequencers. What they need to develop is the workflow for the metagenomic sequencing, because this workflow is different from what people have been using these sequencing facilities for. They are mostly using it for the respiratory virus surveillance or the AMR surveillance. Metagenomic pathway, the processes are slightly different, the analysis is different, but that is something which we need to develop. Next is an interesting case, something akin to what Dr. Krishna Das told. This is a report from an ED where a 3-year-old male presented in Texas, and this was a case where the grams was negative and the microbiologist was not very happy. I have highlighted that part. The microbiology laboratory scientist questioned the negative grams due to high number of white cells and subsequently performed an eclidine orange to better visualize the pathogen. And that is where they picked up the acanthamoeba. So again, it emphasizes the importance of the person who's seeing and the application of mind. I'm not saying that it's only the lab personnel who should be doing. It has to come from everywhere. The entire treating team has to think of patient as one unit and try to find out the diagnosis. Other paper is about the Balamuthia, where they have reported a series of cases, and the role of PCR, where they could detect Balamuthia in PCR, a few from CSF and rest from the biopsies. So the take-home message is the distinguishing between primary amoebic meningoencephalitis and granulomatous amoebic encephalitis has to be done. Microscopy is fastest, but again depends on the expertise. Where the expertise has been developed, as Dr. Krishnadas said, that their residents has also developed the expertise, well and good, but wherever there it is not there, PCR is something which is going to work. It's easy, and again, lot of PCR facilities have been developed over the COVID period. Tissue-based diagnosis is something which we have to develop across, where from the unknown cases, brain biopsies should be preserved so that it adds to the laboratory findings in the unknown cases, something which we do not do, the academic biopsies and the metagenomic sequencings. So these are some things which I thought I should put across, and thank you.
Thank you so much, Dr. Rahul. Next picture.
I just can I make just two very small comments to you, Rahul?
Yes, sir. Yes,
in
sir.
fact, the presentation was good, and I liked it for your pan FLA PCR. Now, my point is, you said one line about the culture. In my experience, once you learn the culture for the FLA, I mean, it's not very difficult. And
yes, sir. It's not at all difficult. Yeah.
So it should not be discouraged, because having just the microscopy is on one side, but if you can supplement just in 4 or 5 days everyday observation on the non-nutrient agar or nutrient agar even with the E. coli lawn culture, just in 4 or 5 days you will be able to see the zone of clearing around the drop of the CSF, and it's an easy thing for any laboratory to do. So that can be done. This is one comment I wanted to make. The other comment is, since I'm having this data in National Centers for Disease Control in front of my eyes, which says 2023, 2 cases, 2024, 39 cases, and 2025, 170 cases. So we see a huge number of cases as compared to the whole world having, say, 500 cases. So it is of area of interest and also to you to understand, out of these, say, 170 cases done in 2025, how many were diagnosed only on the basis of wet mount? How many were diagnosed only on the basis of PCR? And in how many cases, both of them, they were done? If you have the data right now, you can just tell in a very short, otherwise we will discuss it.
I don't have it, sir. I don't have it. That we'll have to get it from the Kerala government. I think they must be having it.
So the similar story goes to the other two clinicians. If they can put their data that way, we can have a separately that kind of a discussion. So on that note, I think quickly we should move because the time is also running.
Thank you, Dr. Naveen. So next we have Dr. Agish. He's Scientist F in Institute of Advanced Virology, Trivandrum. He has a PhD in biotechnology from ICMR, Pondicherry. His academic career began as an assistant professor at Sastra University and later progressed to associate professor at MGM Advanced Research Institute. Dr. Kumar has authored more than 60 international publications and served as a reviewer for leading journals like iScience, JID, and ERG. He is currently serving as associate editor for IJMR, a flagship journal of ICMR, with an editorial member in BMC Infectious Diseases. His research focuses on endothelial proteins and their role in understanding the clinical outcomes of viral diseases like dengue and SARS-CoV. I invite Dr. Agish to take us through challenges and advancements in detection of PAM. Dr. Agish, over to you.
Thank you, Dr. Deepthi, for the kind introduction, and thanks, NCDC, for allowing me to make this presentation. So I'll be mostly talking on challenges and advancement in detection. Please go to the next slide. Since Dr. Rahul has already covered the different diagnostics methods, please go to the next.
There is some disturbance in your audio.
Is it not audible?
No, you are audible, but there is some disturbance. We're not able to hear clearly.
Oh, okay. So there is some issue with my Bluetooth. That's why I'm talking directly. Maybe.
Oh, okay, okay. You can continue.
Okay, please continue.
Yeah. So the snapshot of my presentation would be the shortfalls on the conventional diagnostic methods and the need for advanced methods and some of the emerging point of care diagnostics and key challenges. Yeah. Next slide, please. So since already the conventional methods have been covered, I would tell some of the limitations that has been already told. In a nutshell, the conventional methods have low sensitivity, time consuming, and it also requires experienced personnel and lack of standardized diagnostic protocols and poor specificity in terms of radiology based imaging. Next slide, please. Some of the PCR-based advanced methods have been established. It overcomes some of the limitations which has been mentioned before, like rapid diagnosis, enables species-specific identification, high sensitivity and specificity. For example, multiplex PCRs are already available for the rapid detection of co-infections and species and subspecies levels. And Kerala actually rapidly strengthened its diagnostic infrastructure following the outcome, and some of the public health laboratories in Trivandrum, they have strengthened with PCR equipment, and they are in a position to diagnose all the 5 species, including Nigeria fowleri and Academia. And instead of advanced virology, we also have supported in terms of multiplex PCR and Sanger sequencing initially, and we have screened around 50 samples, and 4 of them are found to be positive for Academia. Next slide, please. Next slide, please. Yeah, so this NGS, when this NGS is considered as a frontline diagnostic test in recurring encephalitis, and this provides unbiased identification of rare or novel species, and it is useful in culture negative encephalitis cases. And some of the case reports were already shown by Dr. Rahul. And one interesting study which I would like to show here is a pediatric case where they have detected the primary amoebic meningoencephalitis due to Neisseria fowleri, both in CSF and blood samples. Though the copy number were found to be low in blood samples compared to that of CSF, they speculated this amoeba could actually enter into the bloodstream through the damaged BBB, blood-brain barrier, and actually, it gets transmitted to other organs. And consistent to this finding, there was another report in which they have mentioned the presence of this Neisseria fowleri in extra CNS organs. Next slide, please. So MALDI is the next advanced technique which is currently available, and again, this is not the frontline diagnostic tool which we have seen as the other cases, but this would be able to provide the protein fingerprints, and that way we will be able to identify the interspecies strain variations. So the technique has been already developed for Neisseria fowleri through mass spec, and it is already available. I mean, it is already available for the detection of various subspecies or interspecies strain variations. Next slide, please. Yeah, and the next emerging point of care diagnostic is rapid antigen or lateral flow assays, which is again based on ICT. So now it is being developed by targeting proteins like surface proteins, HSPs, mannose binding proteins, etc. And this actually acts as a screening test confirmed with PCR or NGS. And this is rapid, simple, portable, and low cost, and it will also help in multiplex detection. On the other hand, the microfluidic based PCR devices are also being developed. All these are in laboratory scale now, which is of high precision, and it is actually a miniaturized PCR in a chip based. So this actually, it requires very less samples, and it allows for the rapid detection from CSF samples. Next slide, please. And isothermal, this is a LAMP PCR, which was again discussed by Dr. Rahul. This is quite interesting because it does not require a PCR machine as such. So it will be very useful for low resource settings. And like if you want to go for a mass screenings in endemic areas, suspected endemic recreational pools or rivers, this LAMP PCR would be very efficient in detecting because like the pilot data shows that the sensitivity and specificity is on par with PCR. And another interesting technique which is being currently developed is CRISPR based. After doing the lab, it can be subjected to CRISPR. This will be more specific. LAMP would be, it may lead to some non-specificity, whereas CRISPR would actually, or the LAMP products can be subjected to CRISPR. It actually targets the specific sites, and then this can be read out with the lateral flow assays. So these are like some of the exciting things that are being coming up in the area. Next slide, please. So to provide an overview, I don't want to tell about the conventional method because that has been dealt already. And coming to the advanced methods, PCR, it requires clinical suspicion of PAM, whereas the metagenomics next generation sequencing, which can be done from CSF or blood, is rapid, accurate, and capable of diagnostic most rare diseases. But one thing is, it is expensive and time consuming. MALDI-TOF, again, it requires technical experts, and it requires expensive instrumentation, whereas the LFE or microfluidics lamp, they have a lot of advantages in terms of rapid detection, fast, low cost, and works in low resource settings. And again, the multiplexing is quite challenging there, and that is, it requires and mostly qualitative, and because of low number of samples, limited validation has been done in terms of all these assays. Next slide, please. And this is an algorithm, which has been mentioned by Dr. Rahul and Dr. Krishna Dash, where wet mount would be an inevitable thing to confirm the positivity. And even after that, like it can go for, the samples can be subjected for metagenomic next generation sequencing, followed by a PCR. So this is just an algorithm which I found interesting, and I thought I will show you that here. So moving on to the final slide, like however the advancements, the critical challenges otherwise, some of the low pathogen load, non-specific clinical presentations, rapid disease progression, and delayed diagnosis. And this actually it hampers the advancements, but still some of the upcoming techniques like CRISPR-Cas, LAMP, and the NGS would actually overcome all these things for the proper early detection of amoebic encephalitis. Thank you. I just wanted to cover the challenges and limitations in conventional methods, and what are the techniques that are currently being developed at research level. Thanks.
Agish, it was very informative. Moving forward, we have Dr. Sumendranath Haldar. He's head of Department of Infectious Diseases and Advanced Microbiology from STM Kolkata. He holds a degree in infectious diseases from AIIMS New Delhi and currently serves as an head of the department. He has rich clinical and academic research experience. He has managed complex infectious diseases, including HIV, tuberculosis, and COVID-19. He is a dedicated educator, consultant, and a speaker. He actively contributes to national health programs, antimicrobial stewardship, and infection control alongside publishing research and guiding postdoctoral medical trainees. I would request Dr. Somnath to take us through a strengthening amoebic encephalitis surveillance lessons which we have learned from the emerging cases. Dr. Somnath, over to you. Sumendranath, over to you.
Thank you, ma'am. First, I want to thank Dr. Simmi Tiwari ma'am and Dr. Naveen Gupta sir and Dr. Agesh for giving me the opportunity to say something about this complicated topic. So next slide, please. So ma'am, am I audible?
Yes, sir, you're audible.
Thank you. So outline of my presentation is spectrum of disease, why surveillance is needed, epidemiological challenges, surveillance protocol for AES, treatment recommendations, case discussions, and take-home messages. Next slide, please. Endosymbiosis. This topic I think discussed already by my previous speakers. This is very important because the Trojan horse mechanism, when an amoebic meningoencephalitis happens, it may be co-infected with some other bacteria, viruses, yeasts, and protozoa like mycobacteria, Shigella, chlamydia, pneumococcus, and or anyone. So it rendered the intracellular microbe more pathogenic, facilitate the gene transfer between the bacteria and amoeba by causing, which contributes more virulence to the organisms. And it allowed the microbe to survive in an inhospitable environment. For that reason, the cases in Kerala are increasing, probably. And it shields the intracellular organism from immune response and antibiotics. Next slide, please. I should skip it because the slide is already described by other speakers. Next slide, please. So why surveillance is needed? Amoebic meningoencephalitis is underreported in India. So this is a very strong statement because till my previous presentation, we have seen the cases are reported from Kerala, but in West Bengal also Acanthamoeba meningoencephalitis cases are reported and published also. I will discuss this later. Between 2024 and 25, I have informed from the seminar that in 2025, 170 cases are reported from Kerala, out of which 42 deaths are there. So effective, ongoing and standardized surveillance is critical for managing the acute encephalitis syndrome and amoebic meningoencephalitis also. It's beyond just case detection. So case reports are there, but this is not under any national program, or it is not still a notifiable disease across the India, if I'm not wrong. So most of the cases are from Kerala. From West Bengal, cases are there. But other states, I think the cases are underreported. For active case management, two things are very important. One is the diagnostic problems, I will discuss later. The treatment algorithms. Till date, there is no national guidelines. The treatment protocol is based on the treatment regimen, most of the times which regimen was used for the survivors. There is no RCT also, that these single versus combination therapy, which one is better? Combination therapy, what is the best combination for treating amoebic meningoencephalitis? This is not absolutely clear. For that reason, burden of the disease, knowing the burden of the disease is very important. Etiological spectrum, like in Kerala, most of the cases are Naegleria. But in West Bengal, in last 2 to 3 years, all cases are Acanthamoeba meningoencephalitis. What are the risk factors? Like in the cases from Kerala, the Acanthamoeba case happened in immunocompetent patients, but in literature it's written the Acanthamoeba meningoencephalitis happens usually in immunocompromised patients. Like Kerala, all of our patients or most of our patients are immunocompetent. So maybe the history and other things which we know from the Western literature may be different from our literature. Next slide, please. So what is the problem with surveillance? microscopic examination of fresh, unfrozen, non-refrigerated CSF for presumptive diagnosis. All three words are very important. It should be done as early as possible. After that, if you get any motile trophozoite, it should be confirmed by PCR. Unfortunately, in our state, in fact, 6 to 1 year back, there was no facility for PCR for diagnosis of that, for amoebic meningoencephalitis. So, first few cases we have diagnosed with the help of Dr. Sumita Kurana ma'am. Thanks, Sumita ma'am. We have done our first 4 cases PCR from PGI Chandigarh. So wet mount microscopy was positive and PCR negative. We have got few cases. So what is the explanation? Maybe all motile trophozoites are not Acanthamoeba, not Naegleria. So maybe some other species we don't know. So next generation sequencing is very important for these undiagnosed cases. At present in West Bengal, PCR testing is available, easily available at NIRBI. It is the National Institute for Research of Bacterial Infections, the previously so-called NICED. It is converted to NIRBI. Kerala has developed PCR-based diagnostic for 5 free-living amoeba. So apart from Naegleria, Acanthamoeba, and Valamuthia, also they have some other PCR methods for Sapinia and Barnamoeba. Although the last one is not very pathogenic. So next slide, please. So in Kolkata, cases of amoebic meningoencephalitis is reported from at least 4 institutes, if not more. School of Tropical Medicine, we have already published 3 cases 2 years back. All are PCR proven cases. At present, we are having almost 16 to 18 cases of Acanthamoeba meningoencephalitis. IPGMER, they are also having 20 to 25 cases of Acanthamoeba meningoencephalitis. Although for the cases of IPGMER, I don't know how many are PCR positive cases. Medical College, they have already published 3 or 4 cases. INK, this is a government hospital. This is a private hospital, sorry. Other 3 are government hospitals. This is a private hospital. They have published 2 cases of Acanthamoeba meningoencephalitis. So all these 4 institutes, they have published already. Other institutions also having cases. Sometimes after diagnosis, they referred to cases to us because at that point of time, miltefosine was available at our institute, but outside our hospital, the availability of miltefosine was an issue. First few cases, clinical suspicion was the clue for which we are able to diagnose the case. Commonest co-infection in our case was tuberculosis. I will share the data later. And so first cases, when we started in 2024, so the dictum was a patient diagnosed microbiology proven cases of Mycobacterium tuberculosis. If after adequate anti-tubercular therapy not responding adequately, then think of amoebic meningoencephalitis for these particular cases. For Naegleria meningoencephalitis, the presentation is like acute presentation, like acute bacterial meningitis. In our cases, the presentation was to some extent chronic. It was not very acute presentation. Next slide, please. So this is published in 2025. So what we should do? Should we send all the CSF specimen for wide mount, or what should we do? For clinical features, no pathognomonic clinical features. For treatment also, there is some toxic drugs. So what we should do? So for acute encephalitis syndrome, 12 institutes from India, they have made a protocol, like 5-level investigations. Next slide, please. Level 1 common causes for meningoencephalitis, like malaria, scrub typhus, dengue, measles. Apart from this, chikungunya, all these things are first level. Level 2, not very common, like herpes simplex, varicella zoster, E. coli, H. influenzae, streptococcus agalacti, streptococcus pneumoniae, leptospira. So these are level 1 and level 2. Next slide, please. Level 3, CSF for MTB by gene expert. If it is still negative, then level 4. So level 4 is testing of throat swab by PCR Nipah virus, testing by TrueNat. West Bengal and Kerala, they are like brother and sister, because all these things are happening in Kerala, in West Bengal, like Nipah also. In West Bengal, I am fortunate that I was a part of that treatment team. We have treated Nipah encephalitis in last year. So, amoebic meningoencephalitis, Nipah encephalitis. So, these most of the times these things are happening in two states, Kerala and West Bengal. So level 5 is approximately 5% of the positive and 20% of the negative samples will be sent for NGS. So I'm just giving the example. Every institute based on their disease burden should make their own protocol. But considering the clinical features and all other things, I must say that where it is very prevalent, like in Kerala, so they have made their own protocol. So for our institute, these 2 or 3 institutes that we are getting cases, we now routinely send weight mount preparation during doing CSF, because it is very easy for doing a weight mount. This is a cost effective measure for at least suspicion, and the resident should take the sample and he should run to the lab. There should not be any wastage of time between doing CSF and examination by the weight mount preparation. Next slide, please. Now, regarding treatment. So, treatment for Naegleria fowleri infection, the CDC recommendation in 2025 are these drugs: Amoebic, azithromycin, posaconazole, rifampicin, miltefosine, and dexamethasone, already described. Just I want to mention one thing, that amphotericin B is effective against Naegleria fowleri, and it is in vitro. There is no activity of amphotericin B against acanthamoeba meningoencephalitis. Second thing is, conventional Amoebic is better than liposomal Amoebic for treating Naegleria fowleri meningoencephalitis, because the MIC of conventional Amoebic is 0.1 per ml versus 1 per ml. So 10 times higher MIC of liposomal amphotericin B in comparison to conventional amphotericin B. Next slide, please. So this is the treatment guidelines by Kerala government. So acanthamoeba meningoencephalitis, a combination of all these drugs: sulfasalazine, pyrimethamine, fluconazole, sulfadiazine, surgical dissection of CNS lesion if it is ring enhancing lesion, plus minus rifampicin, intravenous or oral cotrimoxazole, and flucytosine. Next slide, please. So when these 4 institutes at Kolkata, we are getting those cases of acanthamoeba meningoencephalitis in 2024. We sit together, the neuro department of infectious disease, the department of microbiology, the department of neurology, and the department of medicine. We with epidemiologist also, we sit together and we have made our own protocol at that point of time. So the combined regimen which we used for our patient is rifampicin, fluconazole, cotrimoxazole, and miltefosine. Injection amphotericin B is not in vitro effective, but at some point of time, if it is motile trophozoite, PCR testing is not available. The PCR is not the patient is not responding to therapy. So we are not very sure whether we are dealing a case of acanthamoeba meningoencephalitis versus Naegleria meningoencephalitis. So at that point of time, we may add injection amphotericin B, but this is absolutely the physician's discretion. Steroid decision to be taken by case to case basis. Repeat CSF study, most of the times we are doing after 2 weeks if the patient is clinically responding. If not responding, you can do it after 7 days for presence of trophozoites, motile trophozoite, if it is present in the first sample. Duration of therapy, it was controversial at that point of time. Minimum duration of therapy in our patients, we have given, although the CDC now recommending 28 days, 14 days, but we have given more duration of therapy, like at least 2 to 3 months of therapy. Next slide, please. So these are the treatment regimens which used for the survivors. Next slide, please. This is the CDC treatment recommendation. So the drugs which are used, pentamidine, we never used it because it's a very, very toxic drug. Sulfadiazine, flucytosine, mold active agent. Most of our cases, we have used fluconazole at that point of time, 2024. This is 2025 recommendations. They are now recommending Vori, Posa, and isavuconazole because fluconazole and itra are not recommended due to poor in vitro efficacy. Miltefosine, fortunately, we are getting miltefosine from Government of West Bengal. And last one is not very effective drug. It's not available, and it is also not may not be effective for acanthamoeba infection. Next slide, please. Next slide, please. So no, next slide, please. So I will be discussing only one case. So this is a 23-year-old female resident of Park Circus, which is situated in Kolkata with no history of any exposure to pond or anything. Presented with complaining of holocranial headache for last 15 days, associated with vomiting for last 4 days. After 2 days, she had 2 episodes of seizure. She became drowsy and disoriented. New onset bilateral squeam developed after this episode. General examination did not reveal any abnormality. CNS examination was suggestive of neck rigidity, signs of meningeal irritation. Cranial nerve examination was suggestive of bilateral lateral rectus palsy. So we know this is a bilateral lateral rectus palsy, false localizing sign. It is commonly happening with tuberculosis. Next slide, please. So this was the basal enhancement was there. Cell count in CSF was 145, protein was 136, glucose 15, CVNAT was MTB detected, rib resistance not detected, culture. So this simple clear-cut case of tubercular meningitis. CSF CVNAT detects rib sensitive MTB. Patient was started on 4-drug regimen, standard 4-drug regimen with pyridoxine. Next slide, please. Patient symptom was not resolved despite appropriate ATD and steroids for more than a month. Hence, again, evaluation was done. Cell count was increased to 250, 90% was lymphocytes. Protein was 227 in comparison to previous, it was 135. Glucose was 33, culture no growth. Next slide, please. Next, yeah. So imagine of acanthamoeba, it may be like a ring enhancing lesion. It may be, this is not taken for this patient. This is taken from other patient. So like this is may have ring enhancing lesion. So it is non-specific MRI findings. So clinical features is non-specific. MRI is also non-specific. Next slide, please. But this is a still picture, and it was showing motile trophozoites. CSF weight mount was done and repeat CSF sample. It was suggestive of acanthamoeba. Next slide, please. So after that, we have sent the sample to PGI Chandigarh, and PCR was done there. PCR and culture was positive for the acanthamoeba species. Thanks to Shumita ma'am, because ma'am have given us the opportunity for PCR confirmation of this case. Next slide, please. Now the challenges is more. So we have diagnosed a case of tubercular meningitis with acanthamoeba meningoencephalitis. So the patient will be getting 4-drug ATD, INH, rifampicin, pyrazinamide, ethambutal, and for acanthamoeba, she will be getting ceftriaxone, fluconazole, rifampicin, miltefosine. So see, most of the drugs are hepatotoxic. So at the same point of time, you are giving INH, rifampicin, pyrazinamide, ceftriaxone, fluconazole, 5 hepatotoxic drugs. So the patient developed hepatotoxicity. What should we do? Two different pathologies there. So we have to consider which one is more aggressive. The clinical features simulates which one. So it is a crucial decision, and it has to be taken by the treating physician or treating ID specialist, that what you should do, which drugs to be stopped. If the patient is symptomatic more than 5 to 10 times increase, stop all the drugs. Sequentially start one by one. Like miltefosine and ethambutal, they are not hepatotoxic. So what we usually do, we give some liver sparing medicines like amikacin, ethambutal, levofloxacin. Along with that, miltefosine, azithromycin. So you may have to change the regimen. It's not like that you will be always be able to give the treatment regimen which you will want to do. Like my previous speaker, he is fortunate that the patient did not develop any hepatotoxicity, but almost 4 or 5 of our patient is developing hepatotoxicity because of these combined drugs. Patient with decompensated liver disease, which regimen you will give? That is sometimes a challenge for us, because we are not able to give all the hepatotoxic drugs at the same point of time. So treatment of co-infection is also very important. Monitoring of therapy is very important. How to clinical monitor. If you get motile trophozoites, after 2 weeks, we do repeat CSF. Imaging, usually you will do at least after 4 to 6 weeks, because it's very difficult to expect that it will be improving within 2 weeks or 3 weeks like that. Next slide, please. So the patient was first diagnosed as TB meningitis, then showed acanthamoeba in CSF weight mount. Patient was treated with the appropriate ATT dexamethasone, later added miltefosine, tremoxazole, fluconazole for infection. Patient in between developed hepatitis, managed accordingly. At present, she is doing well. Cranial nerve palsy completely resolved. This is a very important statement. Next slide, please. So the problem statement is diagnosis. So the representatives of NCDC are there. So my humble request to you is, if the PCR becomes easily available, then we are able to confirm the cases more earlier. Because as previously my speaker already told that it takes 6 to 7 days for culture positivity. Although the doing culture is not a very big thing, it's easier. Expertise microbiologist, like fortunately it's available in Kerala, and the microbiologist in our institute, as he is almost regularly seeing the cases, he's having some expertise. But the other institutes in Kolkata, specifically the private institutes, they are not very acquainted with the infection, although sometimes few ID specialists are there who are having very good knowledge, and sometimes they refer the patient to our institute. But I think it should be, the PCR should be widely available for diagnosis of acanthamoeba, meningoencephalitis, Naegleria fowleri meningoencephalitis. Weight mount is non-specific. PCR and culture not widely available. Treatment algorithm, if we are able to diagnose more cases, we will be getting more data. So we will be more confident for treatment of these free-living amoebas. No standard national guidelines are available now, mostly case-based with survivor's data, and availability of drugs, expertise, and management of side effects. Next slide, please. So these are our 7 cases. Now we are having almost 16 to 17 cases. So these are our first 7 cases. Like, see, all of our patient is having some co-infection. So CNS TB 3 cases, hypothyroid leprosy, one case co-infected with cryptococcal meningitis, also HIV positive. One patient presented with brain abscess, rhino. This is the most unfortunate lady. So she has simultaneously having brain abscess due to tuberculosis and rhinocerebral mucormycosis and acanthamoeba encephalitis. She died after 54 days of battle. Unfortunately, she died. Next slide, please. So first 3 cases was PCR positive. Next 4 cases it was not available. After that 1 case we have done PCR was positive. So out of 16 cases, 4 cases were PCR positive. All cases are weight mount positive. Next slide, please. Outcome was in first year 3 cases died. After that, fortunately, we have not experienced any death. One patient was very complicated. He required a VP shunt, co-infected with tuberculosis, almost 7 admissions in last 7 to 8 months. But fortunately, now he is doing well. And first time we treated him, the trophozoite was negative. After 6 months, again he came back, and at that point of time, trophozoite was positive. So recurrence or relapse was there after 6 months. Now he's doing fine with therapy. Next slide, please. Next slide, please. So this is our publications in 2024, first 3 cases. So take home messages are, surveillance is needed to know the burden of the disease, etiological spectrum, and the risk factors. At present, no standard national treatment protocol is available, which is very much needed. Clinical presentation is not pathognomonic and diagnostic facilities are not available everywhere. Early diagnosis and treatment may cure the disease, because we, like Kerala, the death rate in our cases is also like 20%, 15 to 20%, like that. Although most cases are isolated from Kerala and West Bengal, national surveillance protocol to be made for amoebic encephalitis. Thank you for patient sharing. Next slide, please.
Just a minute. Dr. Soumendra, it was a very wonderful presentation. And in your presentation, you highlighted the importance of co-infections. So many cases you had the tuberculosis, you have the cryptococcus, and then the Amoebic also coming positive. And very effectively how you talked about the combination therapies and the side effects and which to be deleted. So your experience will be very useful. And in our subsequent meetings, I really propose my team that if supposedly we have a meeting for building up a national surveillance protocol or diagnostics, we'll definitely invite you for your wonderful work. Thank you. So because of the time, I think we can move to the next one.
Thank you, Dr. Naveen. Thank you, Dr. Soumendra. It was very informative and nice presentation. As of now, we have learned about surveillance, epidemiology, clinical features, and diagnosis. Now, moving forward, we have two interesting presentations. So next is on environmental and One Health risk factors, water safety and sanitation and behavior drivers. It is presented by Dr. Sitharaman. He is Dean and Faculty of Public Health from Sri Balaji Vidyapeeth, Pondicherry. He is passionate about nurturing scientific curiosity. He has more than 22 years of experience in public health, community medicine, and health profession education. His expertise lie in spatial epidemiology, One Health, and Indian knowledge systems. He has reviewed more than 50 peer-reviewed publications. Dr. Sitharaman, over to you for your presentation.
Yeah, thank you. Am I audible?
Yes.
Let me share my screen and.
You will share? Okay.
Yes. Yeah. Can you see my screen?
Yes, we can. 17 participants.
Okay, thank you. Thank you, Dr. Deepthi and the wonderful team at Center for One Health at NCDC. Thank you, Dr. Agiyesh, for having me over. Now, a quick recap. We saw that the disease is rare but fatal, caused by a free-living protozoan. It loves warm, stagnant, fresh waters. Now, how does this particular session fits in? We have had sessions on clinical features, diagnosis, and clinical management. And the immediately previous session was about case-based surveillance. Next will be on IEC strategies. So mine sits somewhere here, and the focus will be on how the risk is created before the disease occurs. So from a public health angle, it's not just a microbiological accident. The disease emerges at the junction of environment, systems, and human behaviors. This is, I guess, a variation of our good old epidemiological triad. So, low incidence does not mean it's a low public health relevance, especially because when the case fatality is very high and the exposure pathways are becoming more and more common. So basically, the disease can be prevented or at least reduced, the burden can be reduced if we better understand the pathways of causation. Like we said before, the disease does not happen in isolation. It is a combination of environmental factors, the systems we have built up, and human behaviors. So these three work together, and when they merge, we get the disease. So this is the point that I want to say. Individually, in isolation, the disease does not happen, even if there is the environment is suitable. If the other two are not conducive, we don't get the disease. And these three intersect, we get the disease. So we will look at each of these. What do we know about the environmental factors? What do we know about our water systems? And what do we know about the behaviors in the coming slides? Regarding environmental conditions, we know that it likes warm and fresh water. Stagnant or slow-moving water, it prefers, not fast-flowing water. And this is something that we are rather less talked about. At the household level, biofilms in tanks and pipes in the houses and in our supply systems. And the climate variability and the heat waves of late have been pushing some atypical occurrences. So we are witnessing some changing patterns which are outside the usual predicted patterns, which we're yet to fully understand, but many of them are related to the climate change happening relentlessly. With regards to water systems and where the safety gaps are, like I was saying, most of these are with this slide is most of the points here are regarding the domestic and peri-domestic points, which are usually missed. We talk about our backwaters and canals. Sometimes we miss these. This could be part of the missing links where many reported cases do not seem to have a classical, recreational sports or one of those outdoor water exposure missing from the case that we often come across. There may be something in our domestic water supplies which promotes the Naegleria to grow. And these are postulates. There are some evidence for this, but we need more studies on these. Maybe one of us public health community medicine people can look into all the reported cases, do a mapping of their household water supply, see if some pattern emerges, maybe. Right, so these are the usual things we talk about, though. Ponds, lakes and canals, river edges where the flow is low, slow, and backwaters. Now, all backwaters are not equally risky. It is heavily context dependent, how brackish the water is, how fast it is moving, the temperature there. All these needs to be factored in when we talk about risk. And temporary tanks are also equally risky if we think in that angle, and so are pools, swimming pools and recreational sports activities and theme parks. Now, these are probably quite common scenes we can expect in Kerala and other places, of course, but they are not all equally risky. It is more nuanced, but we know what happens. Basically, the behavioral drivers are anything that can cause a forceful nasal water entry. It could range from splashing, deep diving, or underwater play. It could be something else which we never really put on the list. Basically, anything that forces water into your nasal cavity. For example, nasal cleansing with unsafe water. Unsafe water being the underlined word here, because nasal cleansing, which is catching up, ironically, from the West, it's coming back to us, the neti pots that we used to have. It's coming back to us with called sinus cleaning or some fancy new names. Point is, unsafe water is the risk factor there. Right there, okay. And I think low risk perception is definitely part of the problem. We are simply not aware sometimes, not aware that it is risky. So definitely risk perception being low is part of the problem. Right, so the pathway is like this: environment and then our built-up system. We behave in certain way, we get exposed to it, and we end up getting the disease. That's the classical pathway there. Now, the take home here is the disease is the last step, not the first in this sequence or pathway. This is a classical case to view through the One Health lens, where humans, animals, environment, all three come into play in an interconnected way. You remember this picture before? Let's just add some more complexity to this. climate change factors add on to the environmental factors, newer infrastructural stresses like the need to provide drinking water to 50 newer villages or like newly developed neighborhoods, that increases the stress on the existing systems. Socio-cultural practices that it could be seasonal, it could be a new practice, they all influence our behavior. So it is a little more complex than these three simple circles sitting there. So what emerges, it's basically a systems problem, not a microbiological problem. It's much bigger than a medical problem if we step back and look. So in One Health approach, a One Health thinking would be needed to solve this basically. So where all can we act? Where can we leverage? Where is our leverage point? Preparedness and for prevention means, you know this picture. So basically the point is break any one of these links, we can reduce the risk. We don't have to we don't have to remove all the linkages. Any one link can be, taken up and acted on, and it will still break the link and we will get reduced incidents. Right, so preparedness, how can we be prepared? Basically, these are I'm talking again from the same three domains. We basically need to recognize high-risk environments, what are the system vulnerabilities, and which are the risky behaviors. If we can understand these, then we can anticipate where risk will emerge, right? So action, knowing that, where should we act? Again, with the same three domain principle only I'm going to be speaking. I can think of four major buckets where we can put our public health action. First is identifying risk and enable warning systems where these risks can occur. And then we need to strengthen our water systems. There is a lot of actions under this bucket. And we should regulate high exposure settings like the rules we have for recreational sports activities. We need to review those and we need to ensure our rules are actually adhered to. And then environmental surveillance is a big thing. Here the surveillance is not for the disease, it is for the risk factors or for the risky behaviors, right? So targeted environmental surveillance. The word targeted is there because for an amoebic disease like this, I don't think it is justified to have a blanket surveillance system. It is not needed. So we need to have a targeted surveillance system set up. Now, with regards to, let's say, water sampling is part of environmental surveillance. I saw some questions in the Q&A boxes. But here's the thing, where to do the surveillance, when, how frequently do we do, what do we look for? These may be little boring for non-public health audience. So I'll just mention that we need to do this, and maybe we can have some other separate session on like the depth of this part. But this is definitely part of the action we need to think of. So putting these together, we should work together as the good old intersectoral coordination, and clinical and public health linkage should definitely be there. It is, we can call it feedback or feed forward. Both ways it should be there, because right now the link between clinical medicine and public health is quite not very strong. There is a time delay also that needs to be addressed if we want to address a One Health issue like this. Right, so I think we are near the end. Summing it up, it is rare, but definitely not accidental. It's a constructed risk. Prevention is possible, definitely. And it requires One Health thinking to see the full picture and come up with the full-fledged solution. So basically, preparedness is not just readiness to respond. It is the ability to anticipate and prevent. That is what I would say real public health preparedness means. Okay, I think that ends my session. We can have some questions and discussions, if any. Thank you.
Thank you so much, Dr. Sitaraman.
Dr. Sitaraman, it was a very wonderful presentation from the prevention point of view. And as you very rightly said, this is a very typical area where the One Health, concept is required. And with the prevention, we can prevent so many cases. And it requires a multi-sectoral approach and the intersectoral coordination. So we move with that. I thank you, and we can move to the next presentation.
Thank you.
Thank you, Dr. Sitharama. It was very interesting. I would request our experts to please keep answering those questions on question and answer section. Moving forward, we have one more interesting presentation. It is given on communication and community engagement by Dr. Biju Soman. He is professor in Sri Chitra Trinamool Institute, Trivandrum. His expertise span in epidemiology, data sciences, GIS, technology, infectious disease modeling, and digital health. He leads the DHR-funded Regional Technical Resource Center for Health Technology Assessment in India and has led major projects on telemedicine, COVID-19, and daily spatial temporal analysis. He has over 100 peer-reviewed publication and guides doctoral master level students. He is a recipient of Gold Award for Best HTA Resource Center PI. He is a life member of IPHA and member of multiple national advisory and technical committees. Over to you, Dr. Biju, for your presentation. I'm going to share it.
Yeah. Thank you. Am I audible?
Yes, sir. You are audible.
Thank you for giving this opportunity. And there's an advantage of being the last speaker. Most of the things have been already told. So I have to just consolidate what are being told and close the section. So can we have the second slide? Next slide. Yeah, the core problem here dealing with this Naegleria fowleri infection or primary amoebic meningoencephalitis is like it's a fatal disease, and death occurs in the first 5 days actually. And as if we delay the taking the patient into the clinic, then that means the risk of death is heightened. So that's what I'm trying to show it in this figure here. The message, the problem is that a clinical team cannot save a patient who arrives too late. That's the dictum. And death occurs within 1 to 7 days of onset of symptom. And if we can have a proper clinical intervention within the first 1 or 2 days of start of the symptom, then we can save the patient. But if that is not possible, then the chance of saving the patient is minuscule. And from whatever we have seen in Kerala, actually some of the activities, some of the IEC materials or IEC strategies and BCC strategies that we have tried out and which work, which haven't worked, actually I'll be taking you into that. But before that, and Kerala, we are seeing recurrent clusters in the recent past because the first case got reported in 2016 or so. And actually till 2023, actually we were having only just 8 cases. But in 2023, actually we have seen a huge number of cases, especially it was limited to certain districts, northern district in Kerala. But in 24 actually and 24-25, we have started seeing cases all over Kerala, and it was not limited to certain water bodies or certain districts and all. And why that happened actually from an epidemiological point of view, we have some postulates like one thing could be this immunity depth after this COVID or the pandemic, because of social distancing and people are not traveling that much, and probably generally there is a slackening of the community's immunity as such. That could be one of the reasons why we were seeing a lot of infections after the pandemic. Second thing could be in the recent times, we are seeing huge increased rainfall and resulting in higher storage of water in many of our dams, and we have to release the dam waters. And when dam waters are released, they are warm water, and they will change the temperature in the river bridge. The temperature stratification gets changed. And the flood waters, the recently we have heavy rains and flood waters, and these dam waters, they will take a lot of sewage and other things into water bodies, increasing the nutrient. So thereby many of the microorganisms will flourish. And those could be some of the reasons why we were having more cases here in Kerala. And another thing is that actually we have a very good surveillance mechanism, community-based surveillance mechanism, where people are aware of the overall health literacy is quite high. And we have facilities all across Kerala for primary treatment facilities. So people will definitely come into the clinic and all. This could be the reasons why we are having a lot of cases and all. And our survival, actually, why the survival is much better than many of the other countries. Like most of the other cases where in USA, Australia and all is linked with the water sports and all. But in Kerala, also, we could surpass the survival rate from other countries. Probably we think that many of our better surveillance mechanisms and the use of this our meltifosine, the anti-leishmanic drug, which was repurposed for this purpose, actually that could be the reason at all. So, but the main core problem is how best we can reduce the delay in care seeking. Can I have the second slide? Okay, so you can see that when we are looking at the delay could be of mainly three things, actually. Like in antenatal delay, I've grouped into three delays. Community recognition delay, because knowing the symptoms, but people might not have the perception that it required emergency care. Or it could be the sort of health-seeking delay. Actually, they know that actually there is a problem, but they're a bit stigmatized, or the cause involved, the distance, or sometimes they'll think it's just cold fever and they'll do some self-medication. And another delay which we have observed is the provider or system delay. Actually, patient is reaching to the hospital, but it's getting misdiagnosed as bacterial meningitis. Many of the private hospitals that the clinicians are not sensitized to the issues, because in Kerala during this summer months and pre-monsoon months, actually we have some heightened IEC activities going on, mainly targeting to the private institutions earlier, but now we are trying to reach out to other centers and all. So from the symptom onset, the family recognizing that should be within a day, the first day itself. If we can get the patient to the clinic, then we can save the patient at all. And then once the patient reaches the facility, the clinician should act fast, act in a protocol-based manner. So that's the crucial thing. Can we have the next slide, please? So that is where this IEC strategies will work. And you should know that both are very much needed. IEC, information, education, communication, is a sort of one-way dissemination. So we can use posters, pamphlet, mass media, and all. Here we are raising awareness and knowledge. It's a necessary thing, but it's not sufficient. That's why behavioral change communication occurs, actually, because people know that it's risky to swim in warm water bodies after rains in summer months and all, but still they do. So probably their perceived risk is low, and their perceived efficacy, they think that it's there, but I will not get it. Or that kind of belief systems are there. And that is where we need behavioral change communication. We have to see what are their perceptions, what are the problem, whether it is something to deal with their perception or something to deal with their self-efficacy, or something they think is the social norm, and something they think is God's will. And also that's why actually we have to, this BCC should be done in a very careful way. It should be theory based. Actually, we have to think from individual-based theories to community-based theories. We have to see in which community, which group can be targeted, what kind of messages. That's a professional activity, this BCC change and all. For example, knowledge and behavior. A mother knows symptoms but believes it's just fever from cold water, will still delay rather than taking the child to the hospital and all. So BCC should address that. So that's what we are going to see next. Can I have the next slide? So I would think that I draw your attention to the table. We have 3 or 4 main audiences. The primary audience should be parents and children. So parents and children can, in our experience, they can be reached through social media and through schools. That's the easiest. When I'm saying easiest means cost-effective way. Next slide will explain that to you. And second audience, no, please stay in the slide. Actually, the second audience should be the health workers, especially the grassroots level workers like ASHAs, ANMs, and our primary health center staff. They should be given proper training to see the risk, warning signs, the risk behavior pattern, and they should have some sort of easy material which they can take into the community as such. And the next comes the community leaders. Actually, they have a major role. Actually, in our situation, the panchayat were heightened. Actually, we can tell panchayat, actually, you can just map out all the potential water bodies in your area and see that they are coordinated or they're protected, and recruit your ASHA workers to go around and reach out to the people who are indulging in risky behavior and all. And also media, the large scale media, the paper, the TV, etc., and all, they're a bit costly. But at the same time, we can reach out to social media. There are a lot of influencers and all. So we have to reach to them and all. But the main thing is that pre-test all messages in the community before we release them. So I just listed out few core messages like fever plus headache after water contact during summer months or pre-monsoon sums, go to hospital that day. Avoid warm and stagnant water bodies. Don't deep dive into it. Don't jump into the water. If you still want to have some religious practices and all, having some water, if you want to dip your head, just pinch your nose and dip. So that kind of messages should go there. And use nose clip if available, although there is no peer-reviewed evidence for using nose clip in the Western countries, they've seen that it works. And we have to give the message like hours matter. If we suspect the disease, don't delay. Reach out to the hospital at the earliest, as if possible, to the public hospital. And we have to convince the people that it is not spreading from person to person, so there should not be any stigma attached, and we have to take the person to the hospital at the earliest. Next slide, please. And these are the IEC strategies, IEC-BC strategies. You can see that the posters and pamphlets, you can see the x-axis, actually the population reach from 40% the posters to WhatsApp and social media, actually you can reach up to 80% and all. But you can see that the posters might not be that costly. That's why the round size, the ring size is smaller. But TV and radio, the ring size is higher, means it's costly. But the most cheap one to reach would be WhatsApp and social media and all, because we can, through influencers, we can get it and all. But when you look at the y-axis is the behavioral change potential. So individual communications have the highest potential, like ASHA or health workers talking to the communities and all. But that's very costly and all. But reaching through the schools and teachers and peer children, so that's one of the best strategy to reach out to the community and all. That's what we have seen in Kerala. Next slide, please. So here, ASHAs as frontline communicators. ASHAs, I mean, the sort of our grassroots level health workers. They should identify high-risk water bodies in their jurisdiction, and they should go to a door-to-door counseling in the affected panchayat or earmarked panchayat even before the start of the season, and immediately refer any post-swimming fever case. Post-swimming, any fever with frontal headache, don't wait, actually refer them to the primary health center. and counter the myth that fever from cold water will pass, but we can't wait. We can't waste the critical time for that and all. And in Kerala, we have seen that there is an average 3 to 5 delay before the first health contact. And first visit to private practitioners often delay proper treatment. And we were not having standardized IEC material at the PSC level. I request that the national level, actually, we had to come up with the proper IEC materials and all. And ASHA, so the field level staff were not trained to recognize or respond. Even the field level, grassroots level doctors, including in the private sector, actually, they should be given proper training before the season comes. And for ASHA, actually, we were having some sort of quick reference card, like fever with headache after swimming, PSC same day. If any stiff neck or vomiting, actually, they should be referred immediately. And drowsiness means they have to call our 108 ambulance system and all. We used to emphasize that the ASHA who stops a child swimming in pond in May save a life before the disease begins. Next slide, please. So this 5-step strategy, we have to start from the beginning. Actually, like I told you that communication or IEC materials can be prepared a priori. But if you want to plan for behavioral change communication, that should be preceded by situation analysis. We have to see that what are the perceived notions there, what are the changes, or what are the behavior that we want to change. We have to target that. And that also we have to target particular sections of the community for that different strategies should be used. So that's why the situation analysis is very important. And message development is very, very important. Message before we mass send the message, actually we have to do sort of pre-testing. And material production is very much needed. Actually, in India, no more we can restrict to the vernacular language, actually, because there are a lot of migration within the country. And in any corner of the country, people speak multiple languages. So we have to produce multilingual, culturally conducive messages and all. And we have to see how the messages, how we are going to implement the BCC activities through ASHA, through school, or through media, through influencers, or through community leaders, and or to political leaders. These are very, very crucial. And in Kerala, the Panchayati Raj system is a very useful entity. Usually work with the health system. And the 5th and most important thing is that monitoring and evaluation and learning should be part and parcel of our BCC activities. From the very beginning, actually, we have to see how the messages are going, how messages are, whether messages are successful, or they need some sort of tweaking and all. Actually, that's why monitoring should begin from the day 0. Next slide, please. So this is my summary slide. So I think that the formative research would be knowledge, attitude, practice surveys, so focus group discussions with concerned groups before the campaign. And I request that NCDC approved IEC packages, if they are available actually in regional languages, will be very helpful as standard packages. And then we'll be able to interest even private hospitals to use that and all. And it should be, the campaign should be integrated with the ongoing activities of the system with NHM or DHS and all, actually, because rather than putting it as a standalone thing, it should be part of the Panchayati activities also. And we should train ASHAs and grassroots level health workers, and they should be given some laminated cards so that when they go to the community, they can flip the card and they can teach them and all. And in Kerala, we successfully use this digital media, WhatsApp and other social media, and also digital media is very rapid response is possible. Although digital media is a tool, sometimes it can backfire also. So we should continuously monitor the digital or the social media to see whether there is any misinformation, then that should be corrected at the earliest. And track time to care as a routine surveillance variable from the very beginning. Every case, actually, when you are seeing, actually, we should be interviewing the case, and when the symptom developed, what was their first contact, and when they decided to come to hospital, and what are the hindrances and all, because it will help us to modify our behavioral change communication on the go. And key take-home messages, I would say that every hour of delay is life-threatening. IEC raises awareness, but behavioral change communication, we are trying to change behavior for that some prior research in that area, contextualizing that messages, contextualizing the IEC strategy is very, very important. And in digital media can be used in a proactive way. And we have to pre-test all the messages before we release them. So the goal is not an informed community. It is a community that acts fast. Next slide, the last slide, please. So friends, as a recap, actually this is a disease. I know the disease is caused by around 200 types of organisms and all, but for public health messaging, I'm taking the only one thing, actually Naegleria fowleri, actually, which is spread through water entering the nasal passages, as it was clearly mentioned earlier. Actually, only with the forceful water getting into the nose, the chance of the organism getting through the epithelia will occur. And some religious practices and all actually can still be allowed, provided people are aware of how to pinch their nose before dipping their head into this temple ponds or other sort of things and all. But we have to address this delay. Probably reducing delay is the most effortless modifiable factor which will reduce the mortality of this particular disease entity. And that can be tried with the community support from One Health perspective, with the involving Panchayati Raj system and other sister organizations like this. Environmental surveillance is very, very important. And now, fortunately, we are moving ahead with the Ayushman digital health system, where a lot of our health records are digitalized. And there are ways in which we can get satellite data on temperature, rainfall, and all. So we should develop a mechanism. Actually, we are working on it in Kerala, whether we can come up with a mechanism for every district, a dashboard where all the health data and environment data are brought together to see whether there is any correlation, so that people can act upon that. My time is up. And so I'm stopping it here. Thank you. Once again, I thank you for giving me this opportunity. Thank you.
Thank you so much, Dr. Biju.
So, Dr. Biju Soman, I think that was a very powerful presentation from the point of view of community engagement, and in particular communication to the community and their behavior change in the practices. And as you rightly emphasize, we'll have to loop in the ASHA and the digital media so as to make it more effective. And definitely, yes, the environmental impact can be studied with the environmental parameters, and then how the interplay happens. So overall, your presentation was the last presentation, and it was a very good presentation. So I thank you so much. And back to the organizer to go ahead with the next slot, so that we very quickly, in another 10 minutes, we close down.
Thank you so much, Dr. Naveen. So we have a small quiz. I would request participants to please take out your phone and scan the QR code. आप अपना phone निकाले, QR code scan करिए. We have more than 200 participants, so I would ask everyone to please scan this QR code, and we will start the quiz in 5 minutes. Please scan it. Quickly. So we will end it. जल्दी जल्दी अगर आप जल्दी जल्दी स्कैन करके लॉगिन कर लेंगे तो इंटरनेट भी तो होना चाहिए सर्टिफिकेट 4-5 काउंट का तो ऑलरेडी देखो पीपल आ गए दूरी रहते हैं तो कैसे तो होगा तो ठीक है 100 से स्टार्ट कर देना ठीक है मतलब आपका है नहीं ये तो सबसे इंटरेस्टिंग पार्ट होता है. We have 27 participants. Quickly, we want to go to more than 100, please, to start the quiz. 40. दो सौ लोग जुड़े हुए हैं अभी तक. We have only 49 registration. Please do it fast so we can start. सर आपका थामुर प्राइड आया है.
कल को भी
We'll stop in 1 minute. I will ask everybody to please scan the QR code and start joining. It's 1 minute. We are starting now. So the first question is, the causative agent of PAM is? So your options are Neiglia fowleri, Entamoeba histolytica, Giardia lumblia, and Acanthamoeba. 50 seconds left to answer. 15 seconds.
5 seconds.
So out of 40 to 30 answered right. Very nice. Moving on. The next question is amoebic meningoencephalitis is most commonly associated with. Your options are warm water bodies, marine environments, cold and dry climates, airborne transmission. So you are right now. Computer 10 seconds left to answer. 43 answered right. Very good. So the next question is, the infection of PAM typically occurs through. Your options are inhalation through nose, mosquito bite, skin contact, or drinking contaminated water. 15 seconds left. It's long. It's not an inhalation. Very good. So the next question is, the primary organ affected in amoebic meningoencephalitis is lungs, liver, kidney, or brain?
छोटे छोटे बच्चों वाले क्वेश्चन है
इसके बाद आएंगे थोड़ा।
सबसे ज्यादा खतरनाक तो को इन्फेक्शन वाला था।
हाँ
क्या क्या करना है पूरा, स्टीरॉइड दें या क्या क्या विड्रॉ करना है।
ऑडियंस नेक्स्ट राइट ब्रेन, किसी ने लंग्स भी बोला है।
मैंने बोला मेरा पहला गलत हुआ।
PAM is often misdiagnosed as malaria, tuberculosis, dengue or bacterial meningitis. हाँ इसमें मिक्स्ड ऑडियंस में उसके हिसाब से कुछ सीएचओ
इसमें
भी
तो
है।
बच्चे भी हैं, एमबीबीएस वाले बच्चे भी।
Good. So the next question, a commonly used diagnostic method for PAM is CSF examination, X-ray, urine test or blood sugar test. मैम आप तो क्या
मैम आपके लिए नहीं है ये।
Both of the parties are enjoying.
52, very good. The next question is, in laboratory diagnosis of PAM, which of the following findings in CSF examination is most suggestive? Lymphocytic predominance with cyst formation, neutrophilic pleocytis with motile trophozoites, high glucose and low protein, or presence of viral inclusion bodies?
नीला वाला।
Good. मतलब लोग, it was a good webinar, it seems. So which of the following best differentiates Neisseria fowleri infection from Amoebic rapid progression with acute presentation, presence of cyst in CSF, transmission through bloodstream, or occurrence only in immunocompromised individuals?
Seven.
5 seconds left.
4.
Good, 20. It was confusing. Second last question, from One Health perspective, which intervention would be most effective in early detection of PAM outbreaks? Screening of livestock population, integrated environment water monitoring with human case surveillance, routine vaccination campaigns, or exclusive focus on hospital-based reporting? Five seconds left. Good. Last question. A patient with AFI, acute febrile illness, headache, and neurological symptom after fresh water exposure, what is the likely route of infection? Nasal mucosa via olfactory neuroepithelium, hematogenous from lung, oral ingestion, or direct skin penetration? This is all. I would now request Dr. Naveen Gupta sir to give us the closing remarks.
So, Thank you all the speakers and my Center for One Health team for bringing all the experts and in particular all the audience who have joined. How many people did they join the thing, the maximum number?
670.
So 670 people, they joined this webinar, and all of you have done very well at the end of it by Kahoot question and answers. And you see, knowledge is something which has to be shared because everybody gains from the other person's experiences. The more you share, the more better you become. So today's this webinar has been very, very successful with the presence of each one of you. So thank you so much. Thank you so much.
Thank you, everyone.
Thank you, everyone. We are closing the webinar.